board. Emma, I've noted apologies from Jane Fletcher, and I note that Maggie Hepburn will need to leave at 12:30. Do we have any other apologies to note this morning?
Yes, we do. We have June Brown as well, has given apologies.
Thanks, Emma. So I'd like to start this meeting by extending a special welcome to our new members of the team who are joining us today. I think we have Paul Mitchell with us, Chief Finance Officer. Welcome, Paul. Just see if your name's there. Oh, maybe not. Not joined us yet. Sandra.
Chair, sorry, Paul's given apologies for this.
Oh.
He's got a national meeting this morning, and given it was a significant clash in his new role, so apologies, Emma, I should have noted that. But he will be with us next time.
Thank you, Sandra, for that. So we'll welcome Paul at the next meeting. But I see we have Fraser Bell with us as Chief Operating Officer. So welcome to you, Fraser, your first meeting in this capacity. It's good to have you. And also to note, Shona Oman-Smith is also our new commissioning lead, but I don't think Shona has joined us today, but great to have new members in the team. I also want to start just advising the IJB that Malcolm Metcalf has stepped down as our secondary care advisor for the IJB. And I want to, on behalf of the IJB, put on record our thanks to Malcolm for his inputs over the past few years. I'm really pleased to report that Stephen Close and Christine Hemming will now both share the role of secondary care advisor to the IJB. For those who don't know Chris and Stephen, they are part of the senior leadership team in the medicine and unscheduled care portfolio, and as such will bring a wealth of experience to the role in supporting the IJB. So welcome to them both. And again, I'm not sure if either is joining today, but we will welcome them in due course. So it's going to be great to have their expertise. So we have a really large agenda today covering a lot of topics. I'd like to start just by taking the opportunity to highlight a few key points. You'll see in our agenda today, we have our annual performance report presented today for approval. This report presents the efforts of the last year around the COVID vaccination programme, the ongoing work of our Link practitioners, and also our Stay Well, Stay Connected programme, amongst many other things. And the report really showcases the great work that our services have achieved despite the ongoing challenges they have encountered. We also have an interim evaluation report on Rosewell House today. Members will remember back in August 2021, we agreed to implement an integrated intermediate care facility at Rosewell. And this was aligned with Healthcare Improvement Scotland. And the evaluation we have today demonstrates the progress we have made towards achieving that vision and highlights the areas where we still need to continue our efforts. I'm really pleased to say that Rosewell House has been recognised as a finalist in the Scottish Social Services Awards under the category Demonstrating an Integrated Workforce. And a team from the Aberdeen Health and Social Care Partnership and Bon Accord Care colleagues will represent the service at an awards ceremony in September. So good luck to them for that. The agenda also brings us an annual update on our efforts around the Fast Track Cities initiative as part of the global focus on HIV prevention, diagnosis and treatment. There has remained really great enthusiasm locally to maintain efforts to progress this really important initiative, and the report today highlights the efforts of the local team despite the adversity created during the COVID pandemic. So lots of really positives today. However, we also recognise that despite the really great progress we have made, there is absolutely no room for complacency. We can see from the national indicators in the annual performance report that we have quite some way to go in some areas and some key areas to look for improvements in our performance. Our new strategic plan outlines a programme of work around this, particularly around prevention, which aims to assist us in reversing some of these trends in the future. And we also hear today in the Chief Officer's report about how our carers strategy is being taken forward, which will be important for our carers in the city. I also want to make you aware that officers have requested that I call a special meeting to determine a matter that can't wait until the next scheduled IJB meeting. This follows discussions between colleagues across all three partnerships in Grampian, looking for a sustainable model of healthcare to support our refugees across the region. We're aiming to have a meeting around this next week, but officers will be in touch in due course with a meeting date and papers for that. So that's all I wanted to say by way of introduction. I'll now just check if we have any declarations of interest or transparency statements. If anybody has anything to raise now, just please raise your hand and I'll bring you in. Not seeing any hands raised. I would want to raise a transparency statement from myself, and that is just to acknowledge that until 2018 I was Chief Executive Officer at Alcohol and Drugs Action, and that's a service that's being considered under item 6.3 in the supplementary report on social care. I've no longer any formal connection to the organisation, so I will stay for the item, but just wanted to be transparent about my previous knowledge of that service. So I'm not seeing any other declarations of interest or transparency statements. Okay, I'll move on then to, oh, Alan. Alan, hello, do you want to come in on this one?
Yes, please. To state I'm a volunteer with Alcohol and Drugs Action, and I just make that clear. So I reckon if I need to leave at that stage of what you need me to do, I don't.
Okay. Others can keep me right here, but it would be your judgment call, Alan, as to whether you feel you want to leave while that's going on, if you feel there's a conflict of interest, or if you feel that your involvement is not direct, and not that you're going to have a vested interest in that. So that really it would be your call. I don't know if others, if that's the right advice to give Alan at the moment.
Hi everyone, Fraser here. Yeah, that's absolutely it. So if the test is whether a reasonable person on the street would consider that the interest that you referred to there, Alan, would prejudice your ability to make a fair decision on the item. So it's your call whether you wish to remain in the room and participate in the item, or declare a conflict of interest and leave the meeting at that point.
Okay, thank you. Thank you.
Thanks, Alan. Okay. So I'm not seeing any other hands up. So Alan, you can let us know when we get to that point if you want to go out, and we can call you back in. Just remind me at that item. So the next item is to consider exempt business for today. We have one item where there are financial details contained. Emma, can you just please explain the specifics around that?
Thank you, Chair. Under Standing Order 28.2, the IGB are being asked to consider the exempt appendices of item 6.3 in private, as they contain exempt information as described in paragraphs 6 and 9 of the Access to Information Act, which relates to the financial or business affairs of a particular person. Thank you.
Thanks, Emma. So colleagues, my intention would be to have as much of that discussion in the public session as possible, and only go into private if people have specific questions around the financial aspects that we're considering. Are members content if we take that approach? So we try and have the discussion in public as much as possible. Okay, I'm seeing nods and thumbs up. That's good. Thank you. Alan, did you want to come back in? Your hand's still raised, or is that just from your previous? Okay, thank you. So just practical things now. Timings for today. We've got a long meeting, lots to talk about. I'm aiming to have a short break, just for a comfort break, just after 11, and then we'll stop for half an hour at around 12:30, so that we finish our formal business by 2 o'clock, and then go into our seminar session from 2 till 3. Hopefully Emma can just give me a nudge when we're approaching those kind of rough timings for breaks. So I hope that's okay with everyone. So now on to our business. As you'll be aware, we always like to start the IJB by grounding ourselves with a short film to remind us of really why we're here, and that is to think about the different people that we are serving in Aberdeen. I'm really grateful to ACVO, who have produced a suite of short films that showcase examples of really fantastic work that's going on in our communities, and really highlighting the vital role people and communities have in helping each other. It's quite difficult to choose one to show today because there were so many, and I would encourage you to look on the ACVO website to see the range of films that are available. But today we're going to showcase the Fresh Community Wellness, which provides opportunities to socialise and exercise for individuals who are struggling with social isolation, homelessness, drug dependency and other issues. So I'm going to hand over to Emma, who does this bit brilliantly and gets the film all set up for us. Thanks, Emma.
Volunteering has been a huge part of my own personal recovery, starting with ADA, Alcohol and Drugs Action, and then continuing through the pandemic. So it's been very community-based, and I identified that for me, there was a need to keep busy even though there was a pandemic. And the Fresh was really an option to put volunteers and people coming along, the options to learn new skills, and also progress with things that might be safe choices. We use what's called motivational interviewing, in that we don't make decisions for people. So coming back to why we do litter picking is people might not be perhaps ready to talk about any problems that are going on. They might not want to speak at all. So having an action, if you like, or a purpose that they can do on the day enables them to come along, contribute, boost that self-esteem, the self-confidence, and be a part of a team, but without having that intensity, if you like, of coming along to slowly talk about whatever that huge thing is that you don't want to talk about, really. But you need to at some point. So it gives that option to break it down.
Well, I guess like most people, you know, I kind of care about my local community and I'm just wanting to help out in that way. But I think particularly during the pandemic, a lot of people have really suffered from isolation and low mental health. And it's really more important than ever to try and reach out to people and make sure they've got the company and activities to do and just an excuse to get out and get some fresh air. For me personally, I used to do a bit of teaching, so I do quite like helping people. I like interacting with people. I like hearing people's stories, I suppose. And kind of like anyone, you know, I think when you're volunteering, you're not just helping the service users, but you're also kind of helping yourself a bit as well. Yeah, it's a strange thing because on paper, like litter picking doesn't sound that fun. It doesn't sound something you'd want to spend your time doing for no money. But when you actually get into it, first of all, it's satisfying because you're outdoors and, you know, you're with people, which is always good. But there's something very satisfying about it. You're immediately making a difference to your local streets, your local neighbourhoods. And, you know, you can just visibly see the changes you're making. Yeah.
My full-time job is it's sales orientated, it's target driven, very, very intense at times, and a completely different opposite end of what volunteer roles are. When we started this, seeing the difference just out over the fields, over towards the beach, yes, there's always more litter every time we're back, but it's never as bad as that first day that we went out and tidied it all up. So being out and about in the local community, we are chatting to the locals, we're hearing directly from them the things that are affecting them.
During COVID and that, my mental health got a little bit of dip. So just to get refreshed, meet some people. That's really what I've been needing, and clean up seating. So kill two birds with one stone. Clean up my community because I'm a Seaton boy and I'm face Seaton, born and bred, and I want to keep myself healthy, mentally healthy. And that's why I came along today. What's our community? We should keep it clean. If I wants to go outside and see rubbish out of it's just absolutely ridiculous. Especially today, we've collected so much rubbish today, and it's been really good for me. And mentally, it's been absolutely amazing for me. I've got out today, and I've got met some new people, and felt good.
I mean, I think one thing that a lot of people have felt is because we've been under lockdown, we've had quite a lot more time alone and maybe a lot more time to sort of think about yourself as an individual, which is fine. But when you're actually volunteering and getting involved with community initiatives, you actually stop being so egocentric and you start thinking about what the needs of other people are. And you know, that's very good for my own personal mood and everything and mental health. But that's making a direct difference to other people as well.
Probably if I would have said a couple of years ago, I'm not doing that, no chance. But I mean, can wait till you come out and actually met some of my neighbours. I live just up the road, and they've only seen a certain side of me. As a young man in an old community, thinking, but then they've seen another side of me. They've gone to volunteer, tidied up the community.
Wonderful thing is, this is our community, or it's my community anyway, Aberdeen. This is where I live, and in that enjoyment you get out of it, you sort of, even people who've come along, likes of today, have just helped remove 8 bags of rubbish, you know, which is not the most pleasurable job. Yet everyone's laughing, everyone's smiling, everyone's happy. It's really rewarding. Yet you've technically volunteered your time cleaning up your own area. So that to me is why it's important.
Thanks. What a great film that is. Thanks to ACVO for the work that's gone into creating those films, and thanks to the volunteers who are working cleaning up the Seaton area. It's such a great example of communities getting together and helping each other, and very relevant for today's agenda that we have our locality plans, item 6.4. So all connects very much with that. We're not going to open up for discussion on that film today, but be interested just to hear after the meeting any feedback from members if they're finding these kind of films useful to have. And you know, I'm sure Maggie can take any comments or feedback on the films or any specifics around the Fresh Community Wellness Programme itself. So we'll move on, but yeah, great film to start with. Thank you. So first of all, then, we're just coming to the minute of the board meeting of 7th of June. Can I check that people are content with that as an accurate record of the minute, first of all? I'm seeing people nodding, so we'll take that as an accurate record. Do we have any matters arising that we want to bring up today? I'm not seeing any hands up. Just want to clarify then, we can close off on page 12. There was an action around following up around Project Search. My understanding is that Martin completed that action, so we are content to progress with Project Search that was discussed last time from Martin's feedback. Martin, do you want to come in on that?
Yeah, thanks, Chair. Just to confirm that the questions asked by the IJB in June have been answered. So I sent that round the members. There's 2 questions in relation to funding and one about the kind of longer term retention of people who had participated in the project. Thank you.
Thanks, Martin. I see 2 hands up now. I've got Dina first and then Alison Murray. Dina, over to you.
Hi, Luan. Thank you very much. In terms of matters arising, I'd like to just point out that I went for the Scotland Abortion Care Summit yesterday, led by the First Minister and Minister Mary Todd, regarding bylaws for buffer zones. And in this meeting, the outcome of that meeting was to ensure that we collect evidence locally regarding anti-abortion protests and any sort of harassment that women seeking these, faced by any women seeking these services. So I know there's a report regarding human rights and equality that's going to come on board. So I want to bring up that the IJB should be an integral part of this evidence collection and should work with the City Council in terms of gathering this evidence, which will help inform a bylaw if a bylaw is able to be proceeded. If not, that evidence collection can go into national legislation process. Thank you.
Thanks, Dina. So my understanding would be that would be Aberdeen Health and Social Care Partnership would be as the delivery partner for the IGB, and I just want to check with officers that the teams are around that. I see Sandy's on the call today, but I don't know if others can come in.
Chair, happy to come in there. I've been in touch with Jenny Lawson, who heads up the legal team in Aberdeen City Council, and keeping in contact with Jenny. I'm aware that Aberdeen City Council considered the matter at a full council meeting last week, and will be reconsidering the matter later in the calendar year. So I'll continue to keep in dialogue with colleagues at Aberdeen City Council, and obviously fully cooperate with them should they require any additional information to support the process that the council's going through.
Thanks, Fraser. And Sandy, did you want to come in?
Thank you, Chair. Just to confirm that, yes, the Sexual Health Service, particularly our medical colleagues, are very actively engaged in this process. So really just to confirm, we are well cited in this context.
Good. Sounds like a really important area that we're able to contribute to. So thank you. Thanks, Dina, for that. Someone else had their hand. Oh, it was Alison Murray. You've gone off the screen, but I think you're still there, Alison.
Yes. Oh, yes. It's just coming back to the Project Search. I do follow them on the Facebook because it's relevant to the group of people I serve. And I was delighted to see that they've announced that several of the participants from last year have got full-time jobs, which is what we'd like to see as an outcome of it. And it's good to see that happening.
Thanks, Alison. That is great to hear, and we look forward to hear more how that really good work progresses over the next few years to help develop our workforce. Thank you. That's good. Okay, if there's no other matters arising from the minute, I'll move on then to look at the minutes of the Risk Audit and Performance Committee. I noted there wasn't anything to escalate, but John, did you want to highlight anything from the RAPC?
No, I'm happy just for any questions on that. That we've had a subsequent meeting, although the minute will come to the next IJB. That was on the 9th of August. But if there's anything from this June meeting anybody wants to query, that would take a question.
Thanks, John. I see Alison's hands up. Alison, did you want to come in on this, or was that previous? Okay, I think it's
no, I did. Sorry. Yes.
Oh, you did.
Yes, it was under the CAMS report. I had a look through it. I was just wondering what the waiting lists were like at CAMS, because I know we get reports of quite a few young people who get what they call the choice appointment, which is like a triage appointment, relatively quickly, and then they're told that it's a long wait until they get the next stage. And certainly we've been waiting 2 years for therapy under CAMS. So I was just wondering what the waiting is like to actually get once you get beyond the sort of initial choice appointment there, whether that's still extending out.
Okay,
so Alison John, sorry.
Yeah, no, I don't think Amanda's here, but unless any of the other officers, otherwise we can get information sent on. But is anybody wanting to come in on that?
Sandra?
No, I think I would agree with you, John. It would be helpful just to follow up the information after the meeting.
Right, thank you.
Okay, so we'll take a note to action that. And your query, to be specific, is your understanding of the choice appointment, what waiting times are like, and then how quickly people are then getting into ongoing support after that.
Yes.
Yeah, okay. Right, we'll note that and we'll take an action there. Any other questions or comments for John on RAPC? No. Sandra, did you want to come back in, or is that from? No. Okay. So we'll move on then. Thank you, John. We'll move to the draft minute of Clinical and Care Governance Committee. I note there wasn't anything to escalate, but Christian is here if we have any questions or anyone wants to raise anything from the minute. I've not seen any hands up. Okay. Thank you. So we'll note the minute. And thank you, Christian, for that. Now moving on then to 4.5, which is the business planner. I'll hand over to Fraser to highlight any points from that for today's meeting.
Thank you, Chair. I would just draw members' attention just to the top of page 32 of the agenda pack, and you'll see some requests for removal and deferral. Hopefully it's self-explanatory. The only comment I would add is just around the hybrid meetings one. Although we're proposing to remove that item from the business planner, I'm conscious that members are due to receive a report on meeting dates for next year in October. So we'd look to cover a bit more information around hybrid opportunities in that report in October. But apart from that, happy to take any questions.
Thanks, Fraser. Martin.
Thanks, Chair. There's an item in the business planner on the winter plan, and I wondered if there was the intention to have some more detailed, separated information on that. There's mention of addressing the winter surge and so forth elsewhere, for example, in the annual report. But I was just wondering if that's an area of business that is that is intended or that needs to have a more specialised focus. Given I think that we're going into an exceptionally difficult winter. So that was my thinking. Yeah.
Thanks, Martin, and I'm pretty sure I think that's everyone's thinking for this winter coming. Martin Allen's hands up. Did you want to come in on the winter planning work, Martin?
Yeah, thanks, Chair. Just to say that there's reference in the Chief Officer report around the surge plan, which really kind of encompasses what Councillor Gregg was talking about. So I think the information in the Chief Officer report will provide a little bit of information there about the fact that we've had a different experience this year in terms of COVID waves, and it's not necessarily just going to be a winter surge. It's going to be the requirement to have a surge plan across the whole year. And the plan is to bring a detailed report back to the IJB at its next meeting in October.
Okay. Thank you for that. I think that's really positive. I think that we're going to see experiences in the winter that we're going to have to learn from for the future. So that's really helpful. Thank you for that. Thanks.
Thanks, Martin. Do I see any other hands up? No. So people otherwise content to note the changes on the business planner that we have today. Okay. Thank you. And then we also have a new planner today, which just outlines the seminar plans and workshops that we've got coming ahead. Fraser, I don't know if you want to say anything on that, or they're kind of self-explanatory, and I guess that planner will just develop and evolve over the next few months. We need to get dates put next to some of the topics, but at least it's all visible in one place now, which is helpful.
Yeah, that's right. We'll keep it up to date, and hopefully members will find that useful over the coming months.
Thank you. Thanks, Fraser. Martin Gregg, did you want to come back in? No, everybody's got sticky hands this morning, I think. Okay, we'll move on. Thank you, Fraser, for those. Now on to 4.7, our standing item, which is the Chief Officer's report. Sandra, do you want to say a few words by way of introduction?
Thank you. So good morning, everyone, and thank you, Luann. I would like to say a few words about some of the key issues in the report, and I'm happy to take any questions afterwards. I'd like to start by saying that I'm delighted that we've boosted our talent team further with the latest additions to our team, and I'm pleased that Shona, Paul and Fraser are here today. Well, Paul will be at another date. As Chief Officer for Aberdeen City Health and Social Care Partnership, and also as Portfolio Lead for Medicine and Scheduled Care and Mental Health and LD, I'm very aware of how fortunate I am, and indeed we all are, to have such a fantastic team, with each of our staff members playing an essential part in delivering our key services, working with key partners in our communities to empower them to lead fulfilling healthier lives and wellbeing. The report before you highlights the benefits of a collaborative approach in a local, regional and national context. Locally, the recruitment and retainment of staff, GP sustainability remain key concerns, although members will be aware that these issues are replicated across the region and nationwide. Great work continues to be done by staff in providing support for the Ukrainian refugees who have and continue to arrive in the city. This demand is having significant impact on staff and resources, including GP practices, but despite these ongoing challenges, we are fully committed to help provide the health and social care services to support all refugees. The Local Outcome Improvement Plan's Annual Outcome Improvement Report highlights some of the challenges people living in Aberdeen face. However, the report shows how by working collectively with a shared vision, we all have a part to play in ensuring our communities across the city are places where everyone can prosper. Regionally, great progress is made by Aberdeen City Health and Social Care Partnership, along with Aberdeenshire and Moray Health and Social Care Partnerships and NHS Grampian, to develop an integrated delivery plan on the back of NHS Grampian's plan for the future. This collaborative approach will ensure that we can achieve our shared ambition for sustainable health and social care for everyone. Aberdeen City Health and Social Care Partnership continues to be fully engaged in the ongoing NHS Grampian work to agree a location for the North of Scotland Treatment Centre also. And nationally, you'll see in the report that following the call for views on the National Care Service Scotland Bill, members of the leadership team are currently working up a draft response, linking in with colleagues in Aberdeen City, NHS Grampian and Boncord Care. In the meantime, our communities have also been signposted to your priorities digital consultation so they can make their views known as well. Cybersecurity and the risks of cyber attacks and the need for non-digital solutions to be readily available should the need arise is another hot topic nationally. But finally, I'd like to add that I'm aware, and I'm sure members are too, of the ongoing challenges faced daily by the Health and Social Care Partnership, health boards and local authorities. However, the commitment and dedication and expertise of our staff and their propensity to work together to find workable solutions and their collaborative approach to service delivery are the reasons why I remain hopeful and positive about our direction of travel now and in the future. Happy to take any questions.
Thanks, Sandra. That's a really helpful overview. I'll open that up for any questions or comments from members today. John Tomlinson.
Okay, thank you very much, Sandra, and yeah, very much welcome the new members to your team and wish them all the best going forward. Just three quick questions. The sustainability of primary care is obviously a really important issue, and you're saying here on page 5 of the report that there's certain reports. Will there be a report coming to one of the committees or to the IJB in due course on that?
There will be,
Sandra.
Sorry, yeah, through yourself, Luann. Yes, there will be, John, but I'll bring in Caroline Howarth, who's on here and be able to give a more detailed answer.
Yeah, we want to do this one right, John. So we've kind of committed to bring it back to the Clinical Care Governance Committee. I think it's the October meeting. We've got quite a lot of things ongoing at the moment, but we will be trying our very best to get a good fit for purpose report to that committee.
Okay, no, that's very helpful, but I see that as really a key element of going forward for the whole system. So although I'm not on that committee, I'd very much welcome a sight of that report or signal as to when it's coming. If I can, Luann, I've just got a couple of other quick questions. One, the health and education collaboration, is that largely, it talks about new citizens, is that for the refugees that's cited here, or what? Who's the target for that?
I'll bring in Fiona Mitchell-Hill. Fiona, do you want to pick up, please?
Yeah, thanks, Sandra. So yes, John, it has been predominantly for, we did it over the summer when COVID was happening. So we did it for our vulnerable children during 2020-21, and I think of the success of that and how beneficial it was to families and children that we decided when, because of a lot of the Ukrainians arrived in May and June, that they then had nothing over the summer. So it was focusing specifically on the Ukrainians over the summer, but there was also all the other activities that were happening for other children and families in Aberdeen City as well that complemented that. Thank you.
Okay, thank you, Fiona. And the final one was seeing the LOIP there and the importance of that for the wider determinants of health and care. Very much welcome if that a copy of that could be sent to. I'd like a copy, and maybe other IJB members would like to say to that as well, would be very welcome. Thank you.
Thanks, John. I'm seeing Sandra nodding. We can absolutely get the LOIPs circulated to everyone. Great. Okay, thank you, John. I'm not seeing any other hands up, so we can then move on if we're happy to note Sandra's report, and we'll move on to 4.8, which is the equalities outcomes report from Alison. I think we'll be talking to this one.
Yes, Luann, thanks. So this report describes the work that has been undertaken in relation to the IJB delivering on the Scottish specific equality duties. Reference has been made to two previous reports, one brought to IJB in May 2021, which contained the report on progress against our previous equality outcomes, and also contained our refreshed equality outcomes and the equality outcome and mainstreaming framework, along with information on how we intended to progress this. As laid out in that report, we were required to take a half-yearly report to the Risk Audit and Performance Committee at the beginning of March, and that the link excuse me, to the papers around about that report are in the content of today's report as well. This report today is the annual report. Again, as we committed to doing last May, it's the annual report coming to the IJB. The Risk Audit and Performance Report link contains multiple appendices detailing the documentation to be used and the support and guidance available to officers. We didn't want to repeat all of those appendices in today's report, but you can access them via the links provided. Appendix A in this report this morning is the last piece of that documentation, assisting the analysis of the findings from a health inequality impact assessment and the capture of recommendations that are relevant to influence policy or service delivery. The report this morning also details work that we are planning to do to continue that progress. I would ask you to note the progress that has been made, and that we will bring the first of the biennial reports that we are required to do under the legislation to the IJB in March 2023. And we will bring the refreshed equality outcomes again, as we're required to do, in March 2025. The report is also proposing a change to the way we report on progress against delivering on our Scottish specific duties going forward. And we are suggesting that we bring an annual report only to the Risk Audit and Performance Committee, and I would seek approval of that recommendation. We just feel, obviously, in the last year there has been a fair bit of progress in terms of getting our processes and procedures in place, and that going forward there probably won't be as much activity to report on a 6-monthly basis. So bringing an annual report to Risk Audit and Performance with the statutory reports that we're required to bring to IJB on a biannual or 4-yearly basis is possibly a more effective way of reporting progress. So happy to take any questions.
Thanks, Alison. I see Martin Gregg, and then Dina. Yeah. So Martin first.
Yeah, thanks, Luann. I just wanted to ask about that reporting frequency and the mechanism. Meeting the equalities agenda is really important, and I'm just wondering if, well, I'm just looking for more reassurance, I suppose, and the reasoning behind the that regularity of reporting back, because this is ongoing business, and there will be cases and issues arising through the year, which will need to be addressed and monitored. So is that, so I'm just looking for comfort that that's a sufficient amount of reporting back, that it's adequate. That's all.
Thanks, Martin.
Thanks.
A fair question. Alison, do you want to go?
Yeah, sorry, through you, Luann. Absolutely, there is a lot of work ongoing, and what we are trying to do now is ensure that this is everyday business, that it is just business as usual. It's not a special thing that we're doing. And the thinking behind the annual report to the Risk Audit and Performance Committee was that, you know, they are the committee that should be giving the IJB assurance that we are doing what we are expected to do in our day-to-day business. But obviously the IJB is, the equality outcomes belong to the IJB, and the IJB are responsible for these. So we wouldn't want to be publishing new equality outcomes or publishing a progress report on how we deliver or how we have delivered on our equality outcomes and mainstreaming framework without first bringing that through the IJB. So that is why we thought we would bring the statutory things that we need the IJB to approve. We would bring them here, and we would bring the day-to-day business or report on progress against the day-to-day business to the Risk Audit and Performance Committee. That was the rationale behind that.
Okay, yeah, thanks. That makes perfect sense, and I look forward to tracking what's happening with the equalities agenda on the RAP committee in the future. So thanks for that. That's reassuring. Thank you.
Thanks, Martin. Dina, bring you in now.
Thanks, Chair. Alison, I was looking at the health inequalities impact assessment, and I have a big question around it. You know, it's about human rights, and I think one of the most fundamental parts that we're missing in this assessment is the right to health. That is not there. The right to health is the fact that everyone has the right to the highest attainable standard of physical and mental health. And this impact assessment tool should be built upon that. And the fact that this human right piece of legislation is not even included in that assessment, I'm a bit, you know, it's a question for me to ask you. It was first incorporated in 1946 in the WHO Constitution, and in 1948 it became a part of the Universal Declaration of Human Rights. And it's a massive part of with the NHS, and I think it's a massive achievement for the UK and Scotland universal health coverage, and it's built upon the right to health. And I think we're really missing the whole aspect of health inequalities impact assessment if we don't make this the center of it, and it's not even mentioned on it.
Thanks,
so
Dina.
My question to you is, why have you overlooked it?
Okay to respond, Luann?
Yes, thanks, Dina. And
yeah,
great to have fresh eyes, I suppose, on things that we're seeing all the time. So Alison, come in. Yeah.
Yeah, thanks. That's a really good question. So I think perhaps you know, it was you know, just one of those things in terms of it was expected that, you know, it's all about health, it's about health inequalities. So perhaps that wasn't mentioned specifically. The template that for the health inequality impact assessment that we used was one that we adopted from Public Health Scotland. So you know, it's exactly the headings that they have used in theirs. So I'm not sure why that wasn't included in that, but I can certainly take a note to find out and see if that's something that we need to do to amend the template. But thank you for raising that.
Thanks, Dina. Yeah, as I say, great to have fresh eyes overlooking these things. Okay, so I don't see any other hands up. So if we're content with the report there are 4 recommendations which are on page 37 to 38. I'm not going to read them all line by line, but we're noting the progress. We're instructing the Chief Officer to submit an annual report to RAPC. We're instructing the Chief Officer to submit a progress report every 2 years in advance of its publication, and instructing the Chief Officer to review the IJB's equality outcomes and submit for IJB approval prior to April 25, which is our next required renewal date. So people content with that, and we'll note the action to go back to Public Health Scotland and query that the fundamental, I suppose, that all our services are built on, that access to health, which is, you know, how services exist, but maybe that needs to be made explicit rather than the inbuilt assumption. So Alison will take an action to raise that with Public Health Scotland. Okay. Thank you, everyone, for those questions, and thank you, Alison, for the report, and indeed for all the work that's going on behind the scenes around this really important agenda for the IJB and for the partnership. Thank you. Okay, we'll move on now to 5.1, which is the appointment of chairs. Emma, do you want to introduce this paper?
Thank you, Chair. Yes, John Tomlinson's 3-year term as chair of RAPC is ending this month. So this report is to request approval of his replacement as chair of RAPC as Councillor Martin Gregg, and to maintain the balance of representation of partners, to appoint Kim Cruttenden as chair of clinical and care governance, both for 3 years and starting on the 1st of November, which is the next RAPC.
Thank you, Emma. Hopefully that's a fairly straightforward process, just to keep us all right with our standing orders. So if I don't see anybody questioning that, so we'll go to the recommendations, which are page 55 and 56, and to agree the arrangements as Emma has outlined. And I would also want to add to that we want to put on record our thanks to John Tomlinson as outgoing chair of RAPC for the work he's done over the past 3 years. I think that's a very good committee and does a lot of really important work on behalf of the IJB. So thank you, John, for your commitment and your contribution to that over the last 3 years. And also thanks to Christian. I know you've just come in and taken on clinical care governance, but thank you to your chairing that you've done to date, and welcome our new chairs into their roles. Okay, good, thank you. I'm not seeing any hands up, so we can move on from that. Item 6.1 then is our strategic risk register and revised risk appetite statement. This is the follow-up and update on the workshop we had recently at the Beach Ballroom. Martin, do you want to introduce this paper?
Yeah, thanks, Chair. So the board has before it a report which outlines the next steps for the IJB to review its risk appetite statement and strategic risk register following the workshop held a couple of weeks ago. So the report outlines some of the views, or most of the views expressed by IJB members in relation to both the risk appetite statement and the register, and outlines the plan's next steps. And these are that the senior leadership team in the partnership and the risk owners will review the strategic risks based on the outcomes of the workshop and present a revised risk appetite statement and strategic risk register to the IJB at its meeting on the 11th of October. It's also proposed that, given the amount of changes happening in the macro and micro environment, that the IJB might want to consider reviewing the strategic risks quicker than they normally do. So normally it's a full review of the IJB's risk register on an annual basis, but maybe the IJB would want to consider bringing forward that review. Just to let members know, the IJB do receive the risk register as a standing item twice a year, as does the Risk Audit and Performance Committee. So I'm happy to take any questions on the report. Thank you.
Thanks, Martin. I'll leave that for open for questions. For those who were there, it was a really useful session to be in the room with people and to be talking about risk and risk appetite. John Cook.
Thanks, Luann. Yeah, I think it's a really good idea that we review things on a more regular basis. It's kind of one of those, you made the comment about Dina bringing a fresh pair of eyes, and sometimes when we've seen the risk register for, I think, 20 occasions or thereabouts, you kind of read what you think is there. So I think a more regular review would be quite helpful. The thing that worries me is the cost of living crisis, and in terms of how that might impact on things like the cost of running care homes, cost of running things like Rosewell in terms of energy bills. So it might just be my natural pessimism, but I wonder if we need to bring that higher up in the risk register now, or do we need to wait for Ofgem to have some Damascene conversion and realise that price caps aren't working?
Thanks, John. Martin, do you want to come back on that?
Yeah, I'm happy to take that away and speak to the senior leadership team. And as we discussed at the workshop, whether it's a separate risk in relation to the cost of living crisis, or whether we look at the strategic risks and make sure that that is referenced within those risks, we'll take that away. But certainly we could bring that back for the IGB in October.
Thanks, I think that would be really helpful. And you know, when I was thinking about framing that question, I was thinking, well, what words would I put in? And I couldn't think of any. So taking them away to the senior leadership team seems like a pretty sensible approach.
Thank you. John Tomlinson and then Martin Gregg. So John, can you come?
Thanks, Luann. Yeah, I would support bringing forward that review. I think two particular challenges. There's the immediate pressures and what that means almost into key choices to do least harm. You know, we're in an almost different way of having to look at some of our delivery and what we do. So I think in terms of risks around that, we should be have our eyes open, and therefore that conversation would be useful. I think the second part of it is that the immediate pressures might risk us taking our eye off the changes or the building blocks that are needed for future sustainability. And it is difficult juggling these two, but to stay on course for transformation. But again, we need to have our eyes open around that. So very much welcome that this is brought forward.
Thank you, John. No, that's all important points. And it's the balance, isn't it, between the future planning and dealing with the here and now pressures. Yeah. Martin, can you come?
Thanks, Luann. I'm really just going to say ditto. I think that we can see in the information provided on risks, there is quite a large amount of oranges and there are reds, and I mean I have particular concerns over workforce pressures, because that's going to, I mean, these are accumulating challenges that we're having to deal with, with rise in energy and other costs, which are going to add to pressures of daily life. It's going to add to the pressures on health and social care. So we have to be able to respond to these more challenging circumstances. So if we have difficulties and risks with providing workforce resources, that's quite fundamental. So I think an ongoing strategic, you know, I think through monitoring the risks, we'll be able to keep an eye on strategic solutions, so that we're, you know, so that we're looking into the long-term future. So I think that's the value of sustaining that monitoring of risks, that, you know, that we are looking at the day-to-day problems, but also the long-term environment. That's all. Thanks.
Thanks, Martin. So sounds like we're supportive of what Martin's proposing, and coming back with the revised risk register and risk appetite statement in October. Martin, are you also going to come back with a sort of proposal for how the frequency of the risk the risk register could be looked at differently, because we have looked at it quite frequently already, but have you a thought in your mind about how we could increase that?
Yeah, I suppose just thinking about that, we need to look at the business plans for both the IGB and the Risk Audit Performance Committee. But I think, as I suggested earlier, whether the IGB want to bring the actual full review back to 6 months once the October meeting's out of the way, that's probably what I'd be suggesting. But that might have to, as I say, have a look at the business plans to make sure that we can tie that into that.
Thanks, Martin. That does sound indeed sensible. Martin, Greg, did you want to come back in? No. Okay. Okay, I'm not seeing any other hands up, so we'll just go to the recommendations, which are on page 61, which are to note the outcomes of the workshop that we had in August, and note that there'll be a further paper coming back to the IGB on the 11th of October with the revised risk appetite statement and strategic risk register, and maybe a steer then as well from Martin as to, do we want to review this fully again in 6 months, subject to that fitting in with the planner. Are people content with that? And I think you'll have noted from the discussions, there's definite, the cost of living crisis and the workforce areas are areas that we're particularly concerned about, which will be reflected in the risk register. Okay, thank you, everyone. I'm noting the time, but I'm thinking if we're okay, we'll just keep going to the next item and then take a break after we've discussed the annual performance report, if that's okay with folks. Yeah, okay. So we're now on to item 6.2. Is this Alison again to introduce the annual performance report? Alison.
Thanks, Luann. Yes, I'll do a quick introduction to this one, but I also have Michelle Grant on the call today. Michelle is a Senior Project Manager for performance and data, so she was very instrumental in developing the report. But anyway, the report that you have in front of you today presents the annual performance report for April 2021 to March 2022, which of course is the final year of our previous strategic plan. Publication of an annual performance report is a statutory obligation. The report details the impressive work that was undertaken despite the challenges of responding to COVID. The report itself is grouped under the 5 aims within the previous strategic plan: prevention, resilience, personalisation, connections and communities. And progress on our enablers is also detailed. We also have the usual appendices relating to performance against national performance indicators and the ministerial steering group indicators. The national indicators allow for benchmarking against the Scottish average. The report indicates some of the highlights from the annual performance report, and the IGB is asked to approve the annual performance report in advance of publication. So happy for myself or Michelle to take any questions that the IGB may have. Thank you.
Thanks, Alison. That's a helpful overview. I'll open that up. I'm sure colleagues will have questions on the report. John Tomlinson first, and you come, John.
Yeah, thank you, Alison, and your colleagues for the report. I'm just picking up on the delayed discharges figure, which, although it's increased, is much less than the Scottish average, and in many ways is a positive message for ourselves. And this links to, we're going to be looking at the National Care Service a bit later, and it's maybe not appropriate that the annual report has this level of detail in it, but as a board member, it'd be really interesting just to understand what we are doing differently in Aberdeen compared to other parts of Scotland, whether this is something, about how we're approaching it, or whether there are other factors. So I suppose it's understanding the reason for that good performance, because I think it's something that we would want to share with others or even build on ourselves to bring that forward. So apologise if this is going beyond the actual annual report part, but as a board member, I'd be really interested in that as one example.
Thanks, John. Alison, do you want to come back in on that?
Yeah, thanks, John. So there are a number of initiatives that we've implemented in Aberdeen, which I think is why we're able to demonstrate that difference. We have the Rosewell House facility, as we've mentioned, and you'll hear a lot more about that later on. But that having that facility being run the way it is gives us a far greater opportunity. That whole frailty pathway in terms of having the close links with Ward 102 and having destinations within the community where we can get people out of hospital when they as quickly as possible when they are fit to be discharged. We have Rosewell House, we have the wider frailty pathway, we have the work that we've done on the care at home contract, which is giving us much more flexibility with the Granite Care Consortium. We have our hospital at home team. So there's lots of ways that we are able to effect these discharges as quickly as possible. That it's not without its challenges. As you can see, the delayed discharges have gone up, but that's as a result of increased demand, really. And I think in addition to all of that, within Aberdeen specifically, we do have that whole system approach that we adopt with our colleagues across Grampian. So we're very alert to every and any opportunity to enable those discharges to come through as quickly as possible. I see Sandra's got her hand up, so I don't know whether she wants to add to anything I've said there.
Yeah, if that's possible, Luann, I'll just come in. Yeah, so I think Alison's gave a really good summary of that, and I suppose it's just to link in from the national picture. There is information that's been coming out about delayed discharges across the past 1 or 2 years, and I think what I would say is that within Aberdeen City, we're either leading on some of that, but I've definitely got all of the things that are in place. Not having local community hospitals means that we have to be innovative and think of different solutions. So everything, as Alison suggested, from our interim beds, step-up beds, step-down beds, but also right through to clearing the team aligning social workers directly with high discharge wards, such as we've got one going into AMIA, which is acute medical ward, but also in 102 and other high areas. So really looking at the front door, along with discharge to assessing hospital home, as Alison said. But I think it's not any one single factor, John. I think it's the fact that because we need to do them all, because we don't have the reliance on other areas, we effectively have to use our community splits to its maximum. And even now where there's new contracts and new approaches to this winter, building on what we've known, there's evaluation reports are coming through and learning. So for example, interim beds, that worked well, but how could we even more improve that and move that forward? So just really supporting what Alison said, but we'd highlight that there isn't any papers that do come out from the teams at Scottish Government, from his, that we're all over those and making sure that if we're not already doing it, that we're at least attempt to do that. So very focused.
Okay, thank you very much for that. And I suppose it endorses the approach that's been taken in the sense of your role, Sandra, on that unscheduled portfolio and the changes that have been brought in by the IJB and the Health and Social Care Partnership. So thank you.
Thanks, John. Sandra, do you want to come back in?
Yeah, sorry,
I
was just to add a point on that. I think one of the key things that has been in place over the past since April last year is the fact that across Grampian we have a Daily System Connect meeting, and then a weekly, but the Daily System Connect meeting is focused on that. So all 3 health and social care partnerships, all of the areas in acute, pharmacy, all of that. They're meeting on a regular basis. I think it is being able to connect to that whole system and not just view it as through a single lens that does certainly help.
Thank you. Thanks, Sandra, for clarifying that. And you know, as John says, it underlines, you know, we took some pretty brave decisions along the way around the tendering for a Granite City Consortium, and other plans that we've adopted, which we're now seeing the benefits of. As Sandra said, not one in particular, but a whole range of activities that the IGB has supported. So thank you. Good question, John. Thank you for that. John Cook.
I was also going to ask about delayed discharge, but it's been pretty fully answered. It just strikes me that, you know, as Sandra was saying, we don't have necessarily the advantages that some other areas have in terms of community hospitals and the like. I mean, those other areas will have different challenges, but it just strikes me that this is an area where demonstrably, I think, in Aberdeen, over the whole period of the IJB, we've actually done pretty well. So I think that's something to celebrate. The only other comment I was going to make was around the way the annual report is written, which is sometimes you can read annual reports, and you know, this one, like those, has got a bunch of information that needs to be included on a statutory basis. Some of those reports, no names, no pack drill, can be pretty dire to read. And I just thought, I just like the way the annual report is written. I like the language, because it's something that a citizen, a lay person, can pick up and get what we're about and get what we're doing. So just like, well done to the report authors. That was it.
Thanks, John. Yeah, really important point, how accessible it is for anyone to read. Yeah, thank you. Dina.
Thanks, Luann. So I just have some questions on the report. Some of the most key indicators of health systems performance is maternal and newborn mortality rates and aging population. One of the questions I have is we've seen the premature mortality rate increase by double. So the mortality rate of people less than 75 years old is going high. I just want to know why. Is that COVID had to do, you know, with these rates doubling up, and we saw a lot of younger people with comorbidities being affected a lot. Does that contribute to this? And you know, is it much more of other factors? I'd like to know a little bit more detail about this. Thanks.
Thanks, Dina. Alison, do you want to come in on that? I would maybe just say by background, when we've had reports previously where the outcomes haven't been what we expected, the team have often gone and done a bit of work to understand the data more and bring that through clinical care governance or back to the IJB. Alison, I wonder if that's the thinking around this, that it might not be a straightforward, simple answer, but there's maybe a bit of work to be done around that. Oh, Sandra's got your hand. Sandra, did you want to come in?
Yeah, please. I think mortality rates are not a single lens that just the Health and Social Care Partnership looks at. I think that we're firmly attached that through the LOIP and through the local outcome improvement plans, because we know that mortality is affected by multiple indicators of health. But I do wonder, we've got Phil Mackey on the call, and I wonder if Phil would like to come in and add any comment on that, just for support on there before Alison comes in.
I'm sorry, Sandra, I missed the first part of your question because my sound dropped out. Could you repeat it for me, please?
Hi, Phil. So Dina's asking what the reason is for our increase in mortality rates within the city, and I was explaining that that's not a single Aberdeen City Health and Social Care Partnership issue, but it's generally down to wider indicators of health. And just if you could give a bit of explanation to that before Alison came in.
Yes, certainly. Thank you for repeating that. I'm not going to go into a long detailed response to that, Dina, but I think that there are a couple of things which are worthwhile noting. This is not an Aberdeen City only phenomenon. We have seen over recent years reductions in life expectancy across the whole of the UK, but in Scotland in particular. The evidence that we've seen so far suggests that that has got relationships to socioeconomic factors, as Sandra's actually describing. I think the question we have is to understand what contribution of the current circumstances within Aberdeen City may be contributing to that in a way which are amenable to short-term rather than medium to longer-term intervention. I think the question that I suppose I have is, we talk a lot in my part of the world about avoidable mortality, and we need to understand that the level of avoidable mortality which is coming now from increased socioeconomic sources, as well as the longer term consequences of poorer circumstances for many people over a longer period of time than just the recent changes in cost of living. So I think I'm happy to have that conversation offline in a more detailed way, but I think these are reflective of a longer series of trends which aren't just affecting us. What we do need to be careful about is how far those are going to be exacerbated by the existing cost of living consequences and the length of time for which those perpetuate.
Thank you. I have a follow-up question for that, which ties into that, Luann. Thank you. So, yeah, I understand health determinants and, socioeconomic factors that can contribute to mortality and morbidity as well. So my other question is regarding primary care and looking at admissions, emergency admissions going up, and again, looking at premature mortality. Is there a correlation between people not seeking primary care at the right time because of the pressures on primary care with GP practices and all of that, and not being able to get the appointments that they want, and then leading on to, exacerbation of health issues? I mean, we've seen cancer waiting times and so many other things as well. So, I mean, that's where I'm trying to understand. In order for us to come up with interventions, we've got to understand the health determinants and the grassroots issues of it to tackle these. So I'm trying to get the wider picture on how this is all interlinked with each other.
I think the simple response is, it is an extremely likely hypothesis, but trying to get to the level of detail that I think you are seeking requires quite careful consideration. For example, we certainly know that during the period of time of COVID lockdowns, people were becoming less likely to seek help and support in primary care. The degree to which that has fed into delays in identification of problem, treatment initiation, is an area that is still unfolding. Certainly we need to accelerate care access, and we need to support those who might have become hesitant about seeking healthcare now. But those are not at the level of granularity I think you're looking for. These are effectively getting the system back to work, in my opinion. What I am interested in understanding, though, is how we understand better the natural history of disease to understand those interruptions, because in some regards we've understood that less over recent years, because we have been able to provide intervention from symptom identification through confirmation into treatment in a fairly straightforward way. Though we do know that even then delays were giving rise to poorer outcomes for individuals in a range of areas. So I think it's a complicated area. I'm not going to kind of give you a fuller response than that at the moment, quite simply because I'm not sure we've got a lot of the data we would need to get to that level of detail.
I'm happy to have a discussion with you after this.
Yeah.
Thanks, Dina. See Sandra wants to come in as well.
Yeah, well, I was just going to say, it feels quite specific and detailed questioning, on some key areas that are actually quite large health issues across the whole of Scotland. So I wonder if it is worth just taking this offline and having Phil to make an appointment to see Dina, and then we can have a further discussion on that.
Yeah, very, very happy to do that if others are comfortable with that approach.
Yeah, that sounds like a good plan. Thank you. Thanks for raising that, Dina. And I would also say there are links with the seminars that we have coming up around mental health and drug and alcohol services as well, where we'll start maybe seeing some more of the detail of how those connections are made and what we can do to play our part in preventing avoidable deaths. So we'll see that in our seminars as well. But yeah, sounds like Phil and Dina could get together after this. That would be a helpful thing. We'll move on then to Martin. Martin Gregg has his hand up.
Yeah, thank you, Luann. I just wanted to make some general comments about the annual report. As a newcomer, it was really helpful to get that view, that view of the good initiatives, some bold examples of initiatives from the quite recent past, all really good to see. So in particular, the case studies were really interesting. And I mean, I was finding that there was a very strong theme of connections, of that element of collaborative working. And you could see that, for example, with the unpaid carers, where there was mention of working with Quarriers and Findhorn Arts, also working with RGU to deliver digital learning. So I mean, all of these examples of partnership working does demonstrate that there is improved service delivery in those areas, in those very precise areas. So it just seemed to me that, particularly as we are getting into a much harsher economic environment, that emphasis on working together, on teamwork, you know, should develop, should become more embedded, and indeed should expand. Certainly it's the council's ambition to embed and enhance operational teamwork. So it just seemed to me that the annual report is evidence of that approach of working with partners. So yeah, so all strength to that theme of connections. So that's all. Thanks.
Thank you, Martin. I see Alison nodding furiously in agreement with the importance of connections. Alison, do you want to come back on that, or just totally agreeing that that's how we want to work? Whole system, wrapping around people and bringing in the right partners. That's the approach.
Absolutely, we take that P in partnership very seriously.
Thanks, Alison. I'll bring in Alison Murray now.
Hi, yes, just going through the national integration indicators at the back, it is still very disappointing to see now only 32% of carers feel supported in continuing their care role. I think while it's lovely to hear the work's going on, and I have obviously expressed concern but repeatedly about the carer strategy being delayed. I do think that is actually a terrible number, and I don't think we should pretend otherwise, that only 32% people actually feel supported in their caring role. And I just felt I needed to say that as the carer representative here. So yeah.
Thanks, Alison. Well, in my opening remarks, that was one of the areas that I felt important to highlight. We're not under any illusions that everything's going brilliantly. We've got huge challenges ahead, and I think it's really important that we do the right consultation with our carer groups and different carers in our communities, so that the plan that we come forward with later this year is fit for purpose and is going to see in future years an improvement in those percentages that we're seeing today, Alison. But absolutely agree with you that that's not where we'd want to be, but that there is a plan coming forward. Alison MacLeod, do you want to come back and anything more on that, or I think we're all in agreement
Yeah,
That's a
yeah,
key area for
absolutely.
us.
Alison and I have had many conversations around about this. Alison is on the carer strategy implementation group and is part of all the consultations that are being undertaken at the minute to bring forward that carer strategy. As you say, we will bring a draft of that to the October meeting of the IGB before it goes out for a public consultation, and then bring the final back in November. So we are fully committed to ensuring that by the end of the year we have that fully informed revised carer strategy.
Thanks, Alison. Alison Murray, do you want to come back in?
Well, yes, that's thank you for that. I did have one other question. That was proportion of care services graded as good or better has dropped considerably from 91% to 78%. I was wondering what was the reason for that fall. I mean, it's still slightly higher than Scotland, but then Scotland-wide only had a 6% fall, and we've had a 13% fall. I was wondering what the thoughts were, the reason for that, and whether things have been put in place to try and address it.
Thanks, Alison. Important point again. Alison MacLeod, is there work going on to understand that, or is there an explanation for that that you can give today?
So I'm not sure I can give a specific explanation as to the reasons, but we know our care homes in particular were very badly affected over the pandemic, and a lot of them had a lot of issues to address over that, but we absolutely have support around our commissioned services. In terms of care homes, we have a dedicated care home oversight group. We have our providers network, and we have qualified people around about supporting our commissioned services to implement their improvement plans to bring their grades back up to where they were before. So I think just to give assurance that we're well aware of that, and we are working on ensuring that our residents get the best care possible.
Thanks, Alison. I see Shona has her hand up, and also Claire. Are you both wanting to come in on that point about the Care Inspectorate gradings?
Yeah, I'll come in through yourself, Luan. Just to, I suppose, to build on what Alison's saying, we obviously have our care home team. We have a care home lead. We work very closely with all the providers, and we work very closely with the Care Inspectorate. As Alison has said, there's been very challenging times for a lot of our providers, and that's why we're providing that ongoing support. We've got really strong governance arrangements, so we meet several times a week as a care home group and looking at the care at home performance, and we were doing that on a daily basis. It's now 3 times a week, but we do build it up if needed. So we are continuing to work on improvements, taking in all the challenges just now with providers, with their staffing, a lot of the guidance that they're working within just now. So just supporting them as much as we can. But one of the grades is something that we are looking at all the time, and we're working to try and improve with the providers. Thank you.
Thanks, Claire. That's helpful. Shona, did you want to come in on this point?
Yeah, it was also just around the care homes and the grades. So I'm trying to arrange a meeting with the Care Inspectorate at the moment to sort of drill down and understand the themes and the rationale as to why the grades have dropped a wee bit lower than the national average in this area, and to see what mitigations we can put in place and what support we can build in to help to sustain our care home managers in their roles, and to be able to deliver the great services that the residents that live in the care home should be receiving. We're also got plans to meet with RGU about a range of suggestions and opportunities that they could help to facilitate the care home managers with My Home Life, which is a programme to help to develop and support care home managers with areas of expertise. So that's a meeting that's been undertaken as well. And I've also got meetings with Scottish Government around the care and oversight arrangements and assurance arrangements, and what that looks like going forward. So there's lots and lots of things on the go at the moment to try and drill down into this and to support the sector more widely.
Thanks, Shona. That's good to hear. That's absolutely under active investigation by the partnership. That's encouraging. Hopefully that gives you some assurance, Alison, around those grade issues. Thank you. John Tomlinson, and then we've got 2 more hands up, Christian and Dina, and then we'll stop for a break at that point because we're over we're nearly at 11:30 now. So but this is important. So let's take our 3 last people and then we'll stop for a break. John Tomlinson next.
Okay, thank you, Luann. Yeah, I appreciate that. I appreciate the timing, but I think this is a really important aspect of our work, because the strategy that we now have and the reporting that we now have are all really great steps forward. I think it's that next level, and Alison will have heard me bang on about this in the past as well. It's being able to understand the problem and the gap, and then what will it take to change it. So I was going to be looking at that carers figure, and I understand how it compares nationally, so it's on a par, but we're all saying actually we need it better than that. So what's in my mind is when that strategy comes forward very soon, I would like to see us reflecting on the gap, what our understanding is of it being like that, and what it would take to, I'm just picking a figure out of the air, to get it up to 50%. So what would be the interventions based on our understanding? And I think that approach across all of these headings would be really welcome for us as board members. And I appreciate it's not just quantitative data, it can be qualitative as well. But just as a simple example, that would help for me take all of this onto the next level. So is that what we would be trying to look at when the carers strategy comes forward?
Thanks, John. Alison, can I bring you in? Is that going to be what we're looking at in the consultation process? That would be where my mind's going to. Yeah.
Yes, absolutely. That was one of the key reasons why we asked for an extension to the timescale whereby we would bring the strategy back, because in order to understand that gap, we need to have these conversations with carers themselves. And of course, a carer it is a multi-faceted being. Other different carers have different needs, so it's not that we can just go and ask a mass of people one question and get the answers that we need. We need to understand the needs of the different caring responsibilities, so that takes time. And absolutely, when we present our final strategy, we're hoping we will be able to say to you, here is what carers were telling us they needed, and here is what we're planning to do to fill that gap. And the understanding is that if we meet the needs of those carers, more of them will respond positively to that question when it's asked again. I wouldn't like to put a number on how many more, but absolutely our aim is to increase that number from where it is just now.
Thanks, Alison. That's really helpful. And it's making me think maybe a little bit like the risk register, we maybe should be using our annual report data more regularly as we take forward changes and link it back to how we expect that we'll see improvements in our future annual report. So yeah, it's something for us to look at when we're preparing reports. Thank you.
Yeah, sorry, Luann. What I should have said is we did use a lot of that data when we were developing our strategic plan. If you recall, in the full strategic plan, there's a couple of pages there with the data, which was our starting point for where we were looking to put our strategy in place.
Yes. So yeah, that's the foundation for our strategy. Yeah, good. Okay, thank you. Hope that answers your question, John. Yeah. You see thumbs up. Okay, go to Christian next, I think, and then Dina.
Thank you very much, Luann. And I just wanted to speak about this report and saying fantastic work has been done this year again by everybody, by yourself and by the staff. I wouldn't like to speak on the data because I do know that these 3 years and last year particularly were so exceptional that they will make it difficult for us to follow up a lot of his data and understanding it. I don't know if we're not going to lose a lot of our time of analyzing data, which have been exceptional anyway, and might not be repeating it. So we will have to see what's happening next year and the year after to understand it better. I'm quite impressed, like John was, Cook, about the connections part, and I think the writing of the report is very good. And I want to highlight one of them, which it is on page 126, when it says that it was the first time Aberdeen had experienced asylum seekers arriving in the city with no resources or extra capacity being provided to support the vulnerable group. I just wanted to congratulate that connection and working with third sector organization, of course, but I wanted to see where we take it from there. What are the lessons learned? Are we going to have a paper coming at one point to the Integration Board to understand a little bit better or what the situation has been, what the challenges were, and how resilient are we to take on more? The city is thinking and is taking on more of asylum seekers. What effect has it got on our staff? Have we got the capacity and the resilience to keep doing it? And have we fed back at any time to the Home Office or anybody else to see what our situation is and our preparedness to take more?
Thanks, Christian. Alison, I don't know if you want to specifically come back on that point. Christian, at the beginning of the meeting today, I indicated we're likely to get a paper and have a special meeting to have a discussion on the Grampian approach to how we support asylum seekers, and that'll be happening very soon. So I think a lot of your questions will be answered in that paper. Alison, I don't know if there's anything else you'd want to add to that.
The only other thing, Luann, was just to give assurance that officers are meeting regularly with government officials and others and feeding back the concerns. So it's not just a case of, we're just taking it as it comes. We are making representation, and we have asked for funding and resources, and have made people aware of the consequences of not getting these. So yeah, absolutely. I think that's the only thing I would add to that.
Thank you. And Christian, I do take your point as well. And I think important that we note that whilst data gets us, data is important, and it does shine a light on some challenges. It's not everything, and we have come through a unique period of time, although we're not actually out of it yet either. So I think data is really important, but it has to be understood alongside human stories and the context of local communities as well. So just having that rounded picture is really important. So it's wise words indeed. Dina, final question from Dina.
Thank you. My question is, I just want to touch on some of the positives of this report as well. We can see the false rate reduced. Now, as much as I don't want to go into the data, because it's going to take a lot of time, I think we need to build on those lessons learned and make sure that we build on that progress made, and which will actually inform the statistic Scotland-wide as well, and give them the lessons that we've learned and how we've managed to reduce these rates. Yeah, just wanted to say that. Thanks.
Thanks, Dina. Yeah, absolutely, I agree. I think, I don't know if it's Aberdeen, but as North East, I don't think we're always particularly good at shouting about how good we are, but I do think we are linked into the national networks and are able to highlight the good progress that Aberdeen has been making and sharing the learning with other areas. I don't know if anyone from the leadership team wants to comment specifically on the falls data. We're happy just to acknowledge that, and certainly the culture is that one of learning and improvement and making good progress. But yeah, you're absolutely right. We've got lots of good examples here that we need to shout about. Yeah. Okay, thank you, Dina. So Alison and Michelle, thank you for bringing forward the report today. I hope you're hearing the positives and the how much the IGB appreciate how well presented this report is, and also all the what a helpful summary it is of all the actions that are taken by the partnership over the last year, but also how important it is that we see the areas that we need to work on, and we'll see the improvement areas coming through in various papers over the coming year. So thank you very much for that. We have recommendations on page 97, which are to note the performance report, approve the publication of the annual performance report, and instruct the Chief Officer to present the annual performance report to Aberdeen City Council and NHS Grampian. So we're all content to do that. Okay, I'm not seeing any objections, but that was a great discussion, and I think important that we gave it sufficient time, because it covers all the important areas of work of the partnership. So we're now going to have a little break. Just remind you that the recording for this meeting still carries on whilst we're in break. So please put your camera off and mic your microphone, unless you want to be recorded when you're having your coffee. Do we want 10 minutes? Is that sufficient time just now, just to have a comfort break and then come back? So we'll come back at 11:45. So I will see you all then. Thank you.
Luann, could I ask you a question?
Sure.
Would you mind if I just ask you something? I've had a message in this morning from Daniela Brawley and Louisa Allerton relating to the item on fast track cities. And they probably neither of them can be here before 1. Now, if they can't, I'm happy. I've got some notes, but I wondered whether you'd be willing to consider swapping round item on link practitioner with fast track cities to give them an opportunity to be here. But if not, stick with the running order and I'll just speak when you get to it. So I'm not asking you to change. It depends if you think that's how the rest of the meeting timing's going.
Yeah. Sandy, when we get to that item, just remind me again, and I'm happy to move that around if the other people that are speaking to papers are here. I'm wondering who will be speaking on link practitioner. Is that come through? It'll be Alison. So Alison's here for the whole meeting. Alison, is it okay with you if that's switched around? That doesn't cause you any difficulty?
Yeah, absolutely. It's actually Ian Robertson from my team who'll be presenting that paper. But as far as I'm aware, Ian is here and able to stay. And if not, I can pick up on that one.
Okay, thank you. So Sandy, if we aim for after 1, is that what you're saying for?
If that was doable, I mean, don't delay. If you get to that point and they're not here, I'll still do it. But it gives them Daniela's in clinical appointments this morning, so she probably can't get here before 1. But that would be appreciated. Thank you.
Yeah, we'll do our best, Sandy. Thank you. No problem. So that should be us all caffeinated, legs stretched, and all that ready for the next part of the meeting. Emma, can you just confirm that we are quoted to begin again our meeting?
Yes, we are.
We are. Thank you, Emma. Great. Okay, so we'll now go on to item 6.3, which is our supplementary report on social care. I think we'll have Neil Stevenson here. Welcome, Neil. Do you want to introduce this paper?
Thank you. Good morning, everyone, and thanks for your time. This morning, I would like to bring the work that the Strategic Commissioning and Procurement Board have been up to over the last few months as we start to look at the services that are coming up to either expire or new services that need to be tendered. We've been working quite hard on that, obviously, at the moment, very much conscious of the marketplace. Very much conscious of the staff out there and also our communities to try and get some stability there. So get this work to you as soon as we can. Of the 5 business cases, I'll just run through them very quickly, Luann, if that's okay. We have 3 business cases from the ADP services. Business case C, which is the main alcohol and drug service in Aberdeen City. Business case D, which again, ADP and is the assertive outreach service. And we're looking to a direct award that service. Business case E is a mental health service. And again, we're looking to extend that contract so new work can be done in redeveloping the services there. Business case F, which is for suicide prevention. There's a lot of ongoing work around suicide prevention at the moment. And here we're looking to extend that contract as well. There are 3 aspects to that particular contract, but that's obviously in the business case. Business case G, which is again the final ADP service for an intensive housing support service, and we're looking to direct award a contract there following extensive work and research that the ADP team have done in terms of seeing who would be able to provide that service. I would like, Luann, just to thank the teams out there. We've had a lot of trouble over the last couple of years getting people around service reviews and getting the work done. And I very much appreciate the work they've supported us with there. In terms of consultation, all the approvals were sought and we've received all the approvals. During consultation, there was a question from finance regarding the funding for one of these business cases. And in terms of legal and finance, they both gave their approvals. This kind of crossed the Alex leaving, Paul starting part of life, and Paul did give his approval to the business cases. So I was very happy he had a chance to see them before they went any further. And really that's about it. Obviously happy to answer any questions here in terms of the consultation. I should just include that there was a question around the duration of the first business case C, the ADP contract, and Luann, you may want to say something on that one, but otherwise very happy to answer any questions. And I believe Simon Rayner is here this morning, along with a couple of people from my team, in case there are any more detailed questions that I need support on. So thank you very much.
Thanks, Neil. And just for the minute, a note that Alan Chalmers has not rejoined the meeting, so he's decided to step out for this session. So Neil, shall we open up now for any questions from members of the IGB today? Just making sure that it's not people just coming back from coffee. There's no questions, but it seems like there are no hands up. So I think that can be put down to that you've done a robust report and explained all the questions that people would have, so people are content to support. There was a query about the duration of contract, but I think that'll be taken offline to have a look at after this meeting, but it doesn't affect what's been proposed to be agreed today. So we can take that offline after the meeting. Okay, so there are no hands up, so I think that means we can go to recommendations if people are content with that. They are all contained on page 148 of the pack. I'm not going to read them all right through, but there's recommendations A to F, which are approving a number of contracts and business cases for tendering, as Neil has outlined. Are we all content to support that? Yeah, and I think all the nodding heads are a signal of the importance of stability for this sector and the importance of giving people providers certainty during these really challenging times. So yeah, I think we're content to do that. So thank you, Neil, and thanks to the team and all the folk involved. Huge amount of work to get things to this point, and that's much appreciated by the IJB. So yeah, thanks everyone.
Thank you very much.
Okay, thank you, Neil. So we'll now move on then to the locality plans, which is item 6.4. Who's going to be introducing the locality plans? I don't have a name actually for this. Is it Andrea?
Yes, Luann.
Yes,
thank
hi
you very
Andrea.
much.
Welcome.
Hi, thank you very much. So this is the first annual report following the publication of the locality plans in July last year. And although COVID has had a negative impact on many of the activities, I think this report really sort of highlights that work has been continuing across the localities over the last 12 months. So, for example, I'd just like to highlight from the South locality, there's been enthusiasm and engagement in community green spaces. And over the last year, there has been numerous community and volunteer-led projects that are promoting the use of green spaces and encouraging food growing across the locality. In the north, are really great examples, the Tesco Youth Hub, which provides a safe place enabling diversionary activities for young people who have been causing antisocial behaviour in the area. And activities included the painting of a mural designed by the young people to personalise their space. This work has contributed to 5 young people gaining their Saltire Volunteering Award and a drastic reduction in the number of antisocial behaviour calls in the area. In the central, we've seen through a partnership working and funding from ACVO, the Seaton Soup and Sannies, which provides soup, sandwiches and home bakes, food from Seafine and entertainment, and helps reduces the social isolation to residents from the Seaton sheltered housing complexes. So as you'll see with this report, it is combined as one large report, but these are going to be separated for circulation within each of the respective localities. What we've also found is the easing of restrictions in writing of this report has been an ideal opportunity to take stock of where we're at and to look at improving the communication and engagement with our communities. Therefore, so we have developed a locality plan refresh roadmap, and this is to give a clear and systematic approach to how we're going to approach the review, prioritise the plan based on actions for change. We've made some developments in that so far, so we have been reviewing the LEG membership. So that's about all I have to say at the moment. I'll keep it short, but happy to answer any questions.
Thank you, Andrea. A really helpful overview, and well, I'm sure we'll have questions from people. Dina has her hand up. Dina, and you come.
Thank you, Andrea. I had a chance to look at the whole report, and I see that in all localities, food poverty and fuel poverty is mentioned on the economic side of things. I just want to know, I mean, I've been volunteering in the last couple of weeks, in the last month, in the last couple of weeks with food banks, and it's the landscape is changing now. The kind of people who are relying on food banks are different from what used to be, right? It is the full-time employed people now running out of money before their next paycheck comes. Citizens Advice Scotland put a report out as well. 1 in 5 people are now running out of their paycheck 1 or 2 weeks before they get their salaries again. So our approach to tackling food poverty, do we need to rethink it? There's food pantries and all of that aspects of like long-term strategies of actually tackling food poverty. Because this issue is more imminent, do you think we need to rethink about it? And then it is a crisis. We are in a crisis moment, cost of living crisis. So the kind of people who are coming here are not the unemployed, are not the homeless, are not the usual people who were coming before. That they are also coming, but we have now other kind of people that are now, I would say through no fault of their own, pushed down the poverty line and now seeking support from food banks, because it has now become the first port of call for anybody who needs urgent support. So how can we have we? I think it's more of the question of, do we need to rethink how we're going to tackle this? That's the question, actually.
Are you happy for me just to come in? Okay.
Yes, come in, Andrea.
Dina, yes, I think you highlight some really pertinent points, and it's a really good question. And that is something that is most definitely on our radar. And we're actually going to be discussing it later this week with colleagues within the partnership and within ACVO and our third sector about how we may actually think about how we're going to possibly support this going forward, because as you very rightly pointed out, that this is going to be a far greater issue for a larger population group than what we would have reasonably sort of thought about in the past. So there is definitely plans to think about how we could actually support this going forward, but these haven't been put into sort of formalised as such as yet.
Thank you, Andrea, and I would love to be a part of that conversation. Thank you.
Certainly happy to talk to you afterwards. Thanks, Dina.
Sounds like a good connection being made there. Thank you. John Tomlinson, I'll bring you in now, John.
Okay, thank you. Just a comment and then a question. Really welcome the themes that are coming through on this around prevention, early intervention, equalities, and I think that will help put in some of the building blocks around our strategic aims for prevention and population health. So it's going to be through from the community views. So my question is around the performance data around the annual report. Is any of that available on a locality basis? So that's one question. And then the second one linked to that is the contextual information about how these different graphics, etc., is that available as communities when they're looking at their priorities, or is it mainly based on lived experience? Thanks.
John, so I just wanted to check, John, are you meaning the IJB, the Health and Social Care Performance Report? Is that broken down by localities? Okay, I think I saw Michelle put her hand up. Michelle, did you want to come in to answer that specifically?
Yeah, I suppose we've not gone down the locality route with it, because we don't have consistent data per locality. You know, some data is reported back by health board, some data is reported by GP practice, and it's really difficult to make those lines in population. However, we do have some data from the HAS report that maybe we might be able to break down further. But I think the sort of lowest common denominator, if you like, in it is the GP practice. So it's not consistent, I think it'd be fair to say.
Thanks, Michelle. And then, John, your second point was about how the public and how members of communities get this information back to them from the localities report, if I've picked you up right. Is that right, John?
But yes, and it's that broader point about what this is based on. So they're working through their priorities, and so there can be the views and lived experience, but it's also to what extent the demographic data, etc., is available to them. Would have been that performance data had it been available. It's just what the priorities are based on, whether it's informed through that data as well as lived experience.
Thanks, Johnson. I think that's maybe a question for Andrea there.
See, Sandra has actually put her hand up there. Was it, but you wanted to answer that one?
Yeah, I'll come in, Andrea, and let you add in anything. I think, John, when the plans are pulled together, remember that was based on working alongside our community planning partners, and it was based on looking at both our localities and also looking at areas of higher deprivation. So all of this is data-led. A lot of the data will be in this report is in conjunction with community planning. So a lot of the data and the data is all on that site as well. So it's very much data-led, but and all of the project charters, everything there has to give clear signs for improvement, what the impact will be in that local area. So very much data-led, and also as well as with local engagement right down to our priority neighbourhoods as well as our locality basis. Andrea, I'm not sure if you want to come and add anything into that.
Just one small point, Sandra, thank you. It was just to say that also that looking at the priorities, we're hoping to actually carry out a little bit of a priority refresh, just to sort of touch base with our localities. So this is sort of planned in September to look at, see that whether those priorities have changed, whether they're still the same. So making sure that it is always fed by our communities and what they've identified is really important to them. So just touching base again, because obviously we know that things have really changed, and obviously we've got this cost of living crisis. So yeah, that will be our next steps too.
Okay, thank you very much. And it's really good to see it coming to life like this in the tangible steps that are being taken. Thank you.
Thank you.
Thanks, John. A number of other hands up now, so I'll go to Karen next. You come, Karen.
Hi, Andrea. Yeah, thanks for your report. I was particularly interested in this because I'm just going to give a wee plug for my ward just now. Seaton Park has just won the Fields and Trust Award. It's the favourite park in Scotland at the moment. So, and I think it is the best park in Scotland, having been brought up next to Seaton Park. If anyone hasn't been here, it really is very beautiful and combines quite manicured areas with quite wild areas, as well as the cathedral and the River Don flowing through it. So 10 years ago, due to lack of funding from the council, a group of volunteers started to look after it, and they've done amazing work. I was at their AGM, and my parents were involved in that too. So my concern is that as someone who's come to politics through volunteering in my community, I worry, especially because a lot of these people are quite elderly, about their health and how we support them. You know, as a councillor, I try to get to as many of these types of meetings as possible and be there, be present. But I am aware that you know, for some of them, their health is declining. And it's often the case with people who are looking after their community. They're often quite exhausted because, you know, there's generally just not enough of them. The other community that's really busy with green, actually raised beds in Seaton, which are fantastic, is from the film that you saw at the beginning, Fresh Community Wellness. And it's a lovely guy called Sam who's been running that. Again, he's suffering a little bit with his health. And I think it's just something that we really need to be cognizant of and think about really the best ways that we can support those volunteers as much as possible.
Thanks, Karen. And I must echo that I think that Seaton Park is a very well-deserved winner. It's a beautiful park, and yeah, I've spent a lot of time there exploring as well. So, and I think that is down to the fantastic work, as you say, that the volunteers and the community have done to make sure that it, you know, is that showcase for how a green space can complement and contribute to our communities. And I think it's a very pertinent point saying that, you know, there's a lot of our volunteers now that are getting, you know, they're aged, and we have to think about their care and their health. And, you know, and I very much think that we should be supporting that going forward. And I think Seaton Park is an ideal opportunity to raise awareness for people to, you know, use the park and make sure that they get out there, enjoy the experience, because obviously it's a great place that can actually contribute to people's good mental well-being. And again, this is something that obviously going forward that we will be looking at the volunteers and how we can sort of expand our pool there and think about taking different things forward. But love to speak to you again off today and look at different ways that we could possibly take forward, or different things that we could take forward. Thanks, Karen.
Thank you. And yeah, really important to highlight that risk around volunteers and, you know, aging volunteers, but also younger volunteers who might have complexities in their lives. So good to see that that's being looked at. A number of hands still up. Phil, I'm sorry, I saw your hand, and I don't know if, did you want to come in on the data question? I maybe missed you there, or is it on a different point?
It is, but it's okay. Just take me in order because
Okay.
it broadens things out.
Thanks, Phil. Alison then, Alison Murray.
Hi, yes, I was looking through all the good things that are happening, and there is a lot of good things that are happening, but I was wondering how much of an equality perspective was being considered. I was particularly on one particular item. It was in respect of a LOIP 5.4, 100% of children and young people have free access to physical activity, which improves their mental health. And this was in the south section, but it says all active school activities are now free, providing accessible physical activity to children and young people in all school settings across the city. Now, I know that is not the case. We have many children who just cannot access mainstream sporting activities, and often that's all on offer. They just aren't able to access the types of activities on offer at their local school. If you have a child with coordination difficulties or processing speed and things like that, you just or just a sensory need to actually take part in a mainstream football group, for example, is just not going to work. And so there aren't actually that many activities on a regular basis in different locations across the city that children with additional support needs can access. I think that's one thing we have get raised repeatedly, and I'm wondering actually with other targets as well, whether that broader equalities consideration has been put in place when you're putting in place some activity, whether you're thinking how people with disabilities or children with disabilities can access those activities. Otherwise, it's lovely for the children who can access it, and it's great for them, but often there are these other groups who just cannot access it.
Thanks, Alison. Andrew, do you want to come back on that?
I think we're really looking at LOIP projects and, my understanding was that all 100% of all schools were making physical activity available for all children. But I think you make a really valid point there as well, that children who are maybe not so mobile as others or have some physical disabilities may not be able to access the same level of physical activity. I do wonder if one of my colleagues, Michelle, who maybe have a bit more of the data around the LOIT projects, would like to come in and support, because I don't feel that I probably could give you the fullest of answers that may satisfy you at this point.
Andrea, I'm also thoughtful that I suppose some of that is out with the IJB remit when we're talking about educational inputs, and maybe that question could be better routed through the council areas. I see Angela's on the call. Angela, do you want to come in on that point?
Yeah, just to agree. I think it is outside of the scope of the IGB, but I think they would want to be supportive and share information. So I'm happy to take an action, Luann, offline to get the profile of the support that we do provide across the community that Alison's describing, and share that offline with members of the board.
Yes. Thanks.
Thank you. I just want to say it's not always physical issues, it's often neurodevelopmental issues as well. Yeah. Children with ADHD, with autism, with other sort of other neurodevelopmental conditions, so often have trouble accessing these services. And I appreciate that, and I would be interested in the feedback on that particular item. But I was also just thinking on a more general basis, how much things like disability and ability to access services on things which also are much more within the IJB remit are considered when we are looking at these different provisions.
Yeah, thanks, Alison. I think it's probably better a rounded answer to be given offline, where we can look at all those together. I don't know if there's anyone on the call today that's going to be able to give that comprehensive answer. So you're looking for information on how are all activities assessed to ensure that there's no barriers to children accessing them, regardless of physical or other sensory disabilities, and whether that's...
And adults. I was just thinking, yes, no barriers regardless of not just disabilities, also language, all the equality agenda, really.
Okay. Well, let's take that offline because I think, conscious of needing to get through lots of other questions as well, but you do raise important points to be considering. Sandra, do you want to come in on Alison's query there?
I suppose it's just a general comment, Chair. I'm just very conscious that the report that's been submitted is the work that we've been doing as part of the community planning. We're one of the multiple partners in there, and I do absolutely recognise the valuable questions that all members of the board are asking, but do wonder when the specific things are not specifically related to IJB and health, whether we could maybe have them beforehand or afterwards, just to really pick them up offline, rather than it feels like we're getting a wee bit into spaces that are not necessarily just within the remit of the IJB and might be better answered by more partners being together.
Yeah, thanks, Sandra. Well, let's look to answer Alison's query offline and through Angela's suggestion, but incorporating the wider point as well. Thanks, Sandra. Phil, I'll bring you in now. Thanks, Phil.
Well, I think actually in the light of what Sandra's just said, I'll take my hand down. I was going to comment more about where some of these issues need to be appropriately considered and resolved. I think the report is an excellent report. I think it tells us a lot about the enthusiasm, tells us a lot about the community engagement and participation. Yep, it throws up questions. It also throws up some deep questions about the nature of prevention. Some of the preventative actions are not going to ever be seen easily in data that relates to a locality in a way that's statistically robust in my lifetime. So I think we need to be really quite cautious of where and how we look for these changes. And that's better done within the context of the wider partnerships rather than just within the context of the IJB work. And I'm more than happy to help and explore some of that stuff. But we could end up speaking a lot of time about things that will take us a decade to be able to have sufficient data to answer the question.
Yeah, Thanks, Phil. And I'm thinking that maybe there's something about having a session with IGB members about that population health approach and how that is much wider than the IGB, but so that we all understand where our focus needs to be, but also the real importance of other parts of the system and the role that other partners play.
Yeah, I'd be very happy, not only through myself, but with colleagues from within the Public Health Directorate and the Council who have a lot of contribution around that population approach to pull something together to help explore that for IJB members.
Thanks, Phil. Well, let's take a note of that, and we can explore that after today. Thank you. So Christian, and then Dina, and then I'll bring this report to a close. Christian.
Yes, to be brief on this topic of data, I'm again a little bit worried about the discussion going into looking at data for South, Central and North. It's wide areas with very diverse communities. So looking at the trend will be interesting, but trying to compare them and making decision on what kind of support these areas needs, I think they are far too large to give that intelligence, that understanding. You take an example for South, there are fantastic example of what's happening in Tory, in my own locality, but that really shows that people will think that the South is only Tory, but it's a lot more of areas which have very different experience. So data for these three localities, North, South and Central, won't help you a lot to define what kind of services you need. So I would agree that we will go to GP areas or to wards to have a better understanding of what it is. So I will urge everybody not to look too much at the data as we are trying to compare them, if possible. Thank you.
Thanks, Christian. And I think that's a very sensible point there about not looking at the localities as a whole, but the individual communities or streets indeed within them. They are very different. Thank you. Thank you for that, Christian. Dina, next.
I'd like to join Phil with the discussion regarding a population health approach. But my question is, Luann, regarding standing orders for this meeting. I saw Councillor Karen Van Sweden participate in the discussion. My understanding is that IJB members in their presence, the subs don't participate in the discussion. So I just want to clarify that if I misunderstood the standing orders.
Thanks, Dina. I think you are right. I'll maybe ask Fraser to come in on the specifics. Our approach has always been, as an IJB, to be inclusive, and I know a number of our subs have come along to the induction sessions as part of getting to know the IJB, should they need to stand in. Fraser, and my approach is just to be open and inclusive, but I'm not sure if what's specifically said in the standing orders about that, because we should absolutely be following them.
Yeah, I don't know off the top of my head, Luann. I'm not as familiar with the standing orders for IGB as I am for the council. I do know that the council recently considered their standing orders with a view to offering more inclusivity for members who weren't necessarily party to a committee. But if you could just bear with me, I'd need to check the standing orders first.
Well, just in the interest of time, why don't we take that offline for today? Dina, we'll pick that up. And we need to follow what the standing orders are. I guess that's my approach is to be inclusive. But if we're doing something that we shouldn't be doing, then we can remedy that after this meeting. Is that okay with everyone? Yeah. Martin, sorry, you've snuck in with another hand up.
Yeah, sorry, my hand was up previously and I took it down. So thanks for letting me in. Yeah, I thought that this was a really welcome report because it gives us so much information about what's happening in localities on the ground. And it's crucial that we've got an understanding of what is happening in people's daily lives in the communities. There's quite a diversity of activities. Some I was less clear why they related to the health and social care agenda, such as adult learning. Others more so, such as the diversionary work in the Tesco hub and so forth, and the work of street sport. All of that promoting sporting activities. That makes perfect sense to me. And I just wondered if there was a need, perhaps, to have a clearer understanding of the strategy that we have as it of the preventative strategy that we have, and as it relates to the localities. I wonder if that focus might be possible, if that could be defined more clearly. We saw that film from Seaton, and that to me was a very good example of social prescribing. And I would like to, well, personally, and I think many people would like to see more of that. So it was a very good example of people coming together, teamwork, dealing with forms of physical and mental health treatments by working together. And things like that, and things like street sport, have got quite modest amounts of investment and yet considerable long-term benefits. So I just think it's something that we should, if possible, be prioritising, even if it's just flagging it up. I notice that we have a seminar planned with Sport Aberdeen. I wondered if that was an opportunity to talk more about how we can coordinate more with developing connections for sport and physical activity, and that slightly wider agenda of social prescribing. That's all.
Thanks, Martin. Don't know if other members of the leadership team want to come in on that, but that's my understanding of the seminar topic that we have there, is to explore for how that relationship could be developed further with the IGB, with that very much that early intervention prevention approach in our minds. So yes, I think you're right that is an opportunity to explore that further. And I think our strategy does prioritise prevention and how we do that. And we'll see that coming through in our performance reports over the next year. Alison, do you want to come in on any specific metrics that how we're measuring our prevention activities, or indeed Sandra, to come in on that?
Hi, Luann. Yeah, I'm happy to come in. Prevention is one of these things that's very difficult to measure on a short-term basis. A lot of the prevention activities that are being undertaken at the minute, we're not necessarily expecting to see significant changes in behaviour, etc., for a number of years. So it's difficult to put some metrics on that in the short term. But certainly, I was taking notes as Councillor Gregg was talking, and I'll away and have a look at if there is anything that we can bring forward specifically around about the prevention agenda.
Could I just mention that? Yes. I know that there are short to medium term differences that can be measured through the analysis. So, I mean, wherever possible, I would be promoting those opportunities to carry out the research and the evaluations. For example, street sport has shown demonstrable benefits in the communities where it operates, and that happened very quickly. So I appreciate that there are different forms of interventions and the ways of and the metrics and the performance measuring does vary, but I think there are some positives. There are some positives that we can see, and I think they should be highlighted and celebrated.
Absolutely, Martin. I'll bring in Sandra and then Andrea.
Yeah, thanks, Luann. I think just to say there's been a lot of really helpful questions and narrative that's been raised during this, and I think it will be helpful to just pull aside. Maybe we'll look at one of the seminar dates to bring in what's our wider approach to population health, and also how, as the report highlights, how we work with our multiple partners, and possibly having both of those at the same session might give our IGB members and colleagues just that wider assurance that we've formed part of larger COGS, and then that way how that's been impacted on the preventive agenda, how we're working with our communities, and how that's all getting pulled together. So lots of really helpful questions. Officers will certainly take that on board, and that'll really help us frame a session, I think, that will be helpful for one of our seminars, just to pick up all this detail. Thank you.
Thanks, Sandra. Yeah, no, that's helpful. And I think I will go back to Martin's point earlier about connections and understanding the connections and what's within the gift of the IGB and what sits elsewhere. But the sweet spot is how we work together and how we get those connections working really well. So yeah, it sounds like we've got the basis of a really helpful seminar coming out of these discussions. So thank you all for that. I see Andrea's hands down, so I'm hoping that's okay, Andrea. I'll just go to recommendations now for the report. Really, as Sandra said, really helpful discussion. So the recommendations are on page 155 and 156 of the report. I'm not going to read them word for word, but there's 4 of them, and we're considering the report endorsing the approach to working, doing more on locality working basis, seeking an annual report on locality plans to be presented to Community Planning Board in September, and instructing the Chief Officer to report to Risk Audit and Performance in 12 months with an update on locality planning. So we keep that very much in our sights. So are we happy with that? People content with that? And we'll also note in the minute the discussions we've had about population health and prevention, and look to form a seminar around those topics to help shape our thinking and understanding. And we'll also, in the midst of that discussion, we'll come back about the standing orders regarding substitutes roles around the IGB. Okay. Content with that, so we'll move on then to our next item, which is the workforce plan that we have today. Who's going to be introducing this today? I see Sandy. Is it Sandy?
Stuart's going to start, Luann.
Welcome, Stuart.
Thank you, Luann. Good afternoon, everyone. The report before you today covers the initial steps taken to develop the first draft of our Aberdeen City Health and Social Care Partnership Workforce Plan from 2022 to 2025. The Scottish Government laid out a clear framework in the publication of the National Workforce Strategy for Health and Social Care, which our workforce plan builds on and focuses on. Essentially, our workforce plan focuses on 3 key themes: recruitment and retention, which has been mentioned today already in the meeting, mental health and well-being, and growth and opportunities. And as you would expect, there's a lot of crossover with our strategic plan, and the timeframes obviously align as well. As the report highlights, there's been key three deadlines, the first of which we've managed to meet at the end of July in terms of submission of the first draft. And there's been a lot of work undertaken by the Workforce Plan Working Group, who initially met every few weeks and then weekly up until the end of that first deadline. And there's much more work ahead of us, as I'm sure everyone is aware of. It's not finished. It needs to go out now for wider staff consultation across the workforces and the various staffing groups. And we're also awaiting feedback collated from the Scottish Government, which we're due to receive hopefully by the start of next week. All of this together, combined with the feedback we've already received and will receive over the next few weeks, will ensure that our workforce plan is ready in final form for the IJB in October 2022. We obviously need to ensure alignment with our colleagues in Aberdeen City Council and NHS Grampian in terms of their workforce plans, and that is underway as part of the membership of the Workforce Plan Working Group. But not to jump the gun here in any way, shape or forms, but in terms of initial feedback so far at this very early stage, there's a number of areas that have been highlighted for us to consider, including the inclusion of the Granite Care Consortium, Bon Accord Care, workforces, etc., and their plans. And we already have the detail for this, so that's something that we're currently working on in the background. Our alignment to a risk register, which again has been mentioned today in our appetite statement. Health inequalities when we're recruiting and access to international recruits, which has been mentioned in the Risk Audit and Performance Committee too. Obviously, our how we embrace digital technologies and how that lets us move forward is within the plan at the moment, but I'm aware there needs to be more detail considered for that, and our aspirations in terms of how we want things to look over the next 3 years. But I think we've discussed before that although that might not get into this particular iteration of the workforce plan, it's something that we can continue to work on with our data colleagues moving forward. I've tried to keep that very brief introduction succinct as I can. I'm more than happy to take any questions. And if I can't answer them, I'll just look nervously towards Sandy and hope that he can help me answer some of them. So thank you very much.
Thanks, Stuart. And I think it's really helpful for us to see this draft so that there is the opportunity to help shape the final plan before it comes to the IGB later in the year. So really appreciate this early sight. So we've got 2 hands up. I see Dina and then John Tomlinson. Dina.
Thank you, Luann. So on this report, we're speaking about recruitment and retention. Last week, I actually had a meeting with JNUN, which was actually organized by Fiona, who's on this call, regarding international recruitment. There is some work being done regarding international recruitment, and I've previously highlighted the importance of international recruitment, particularly when it comes to retention, because the employees that come through international recruitment tend to remain in the job because their job is tied to their visa, usually up to 5 to 6 years, right? So it's an added benefit that we're getting through international recruitment. So there is a lot of work done within the NHS, particularly Jane Ewan and her colleagues, just four people doing this major operation of international recruitment. And we in Aberdeen are spearheading this in this sector, which is not really done much across Scotland. So we need to have a discussion with the Centre for Workforce to enable to look at more international recruitment strategies, and you know, we're speaking about issues not just right across the board in terms of you know, recruitment problems. And I think I just want to know what work can we do, and how we can actually support this team to look at this issue even more.
Thanks, Dina. I see Sandy's got his hand up. Do you want to come in and answer Dina's question about how we can do more of international recruitment?
Yeah, thank you, Dina. I guess a couple of things occur to me. One of the big part of this, obviously, we have to work closely with NHS Grampian, whether they're trying to get people from Australia or wherever. So we have to do that with them, but we are trying hard to do that. I suspect the profile of people coming to Grampian or to Aberdeen is mainly to work in hospitals, and that's probably the kind of stuff that attracts them. But we are working closely with them. But I guess it's a slightly different answer to your question. But we're also trying to take advantage of things that suddenly appeared in our door. So we've got the kind of unfortunate, in one regard, very unfortunate Ukrainians coming to the city. But I am trying and working really hard with a wide range of NHS and social care colleagues to maximise the opportunity that they provide. So, for example, we believe there are doctors there, we believe there are nurses there are people interested in social care. So we're trying to take opportunities that are on our doorstep and move people from new to the city to being rooted and living in the city. So your point's a good one about people being committed to stay. So they're two different examples, but we are very actively trying to work on both of them.
Thanks, Sandy. Stuart, did you want to come in as well?
Yes, thank you, Luann. Just to kind of build on that, one of the priorities you can see on page, I think it's 216 if I've got it right, or is it 216? There's 2 there where we do need to link into this and explore the detail around that. And I think as we move from the development of the plan into a more delivery stage, we can explore that obviously in more detail. And I'm conscious as well that we're mentioning our NHS Grampian colleagues. We also have our ACC colleagues, Granite Care Consortium colleagues, Bonacaird colleagues. We have a wide range of staffing groups and workforces to cover with this plan, which has presented some difficulties for us because you're covering extremely large workforces, if you like, plural. So trying to bring all that together into one plan, that's where our alignment with the various other workforce plans that come into play here will help us build that picture a bit more clearly. But certainly international recruits is something that is definitely on the agenda. So just looking to provide some reassurance there that that is and will be taken forward.
Thanks, Stuart. Thanks, Sandy. It's helpful to get that assurance. John Tomlinson.
Okay, thanks, Chair. Yeah, when I was reading through this, I was conscious of a few things I expected to see which weren't there, but Stuart, you've highlighted a number of areas that need to be incorporated. On a couple of those, just wanted to clarify. So you mentioned health inequalities, and the report that went to RAPSI committee back in March, if I'm remembering it correctly, had something around the specific workforce that's reflective, representative of the communities that we care for. So, but I don't see that explicitly in here. Is that the kind of thing you mean is going to be brought across to be part of the workforce strategy? So that's one question. The second question is the aspirations that you talk about. Does that mean identifying particular gaps in the workforce and having an aspiration to close those particular gaps? So we explicitly say, or specifically say, what we're targeting.
Thanks, John. We'll go to Sandy. Is it Sandy, you coming in on this first? So two questions there from John.
A couple of really good searching questions, John, and I guess the honest answer is with Stuart and I would say there's probably more detail we need to put in there to pick those things up. But I guess the kind of things that you're thinking about occur to me that we need to do more of. One of the reasons that Aberdeen Health Village is based where it is the people who thought of the idea wanted it to be a recruiting area, if you like, for the people who live in that area. And many people did come forward on that basis. It was kind of conscious urban regeneration. And I can also think of one of the projects run in the third sector, Huntington's project, where it was put in a kind of council area where kind of no other jobs were put, intended to try and bring in people to work in social care. So I think it's a really good point, John, that we probably haven't really majored on, but there are some good examples in the city of people who previously thought if we put X there or do Y there, local people will come forward and work there. And to be honest, we probably need to put more of that, Stuart and I, in the sort of second draft.
Thanks, Sandy.
That's helpful on that first question. Thanks, Sandy.
And then John's second question on, when Stuart talked about aspirations, is it about identifying and being clear of gaps and how we're going to fill them? Stuart, do you want to come in on that question?
Yes, thank you, Luan. And absolutely, that is the intention. John, this was actually raised by Luan when we first put the draft pre-agenda side. So it is about, we talk about in the strategic plan, and we talk about things like we have vacancies, clinical services, social care, etc. And it's about being aspirational, not just with our data, but with our intentions to say, in 3 years' time, where will we be, for example? And this is why it's sometimes very difficult. And I'm conscious saying this when Michelle's on the call, but we will need, for example, X amount of staff and X amount of services. Sandy's very quick and keen to remind me at every stage when we've been developing this that retirals will form a big part of future planning too, and we need to be cognizant of that moving forward. So there's a lot of things that come into that aspirational focus that need to be further developed in the plan that you should see come the second draft or final draft in October.
Thank you.
Okay, thanks, John. Okay, I'm not seeing any other hands up now, so if there isn't any more questions, we'll go to the recommendations, which are on page 195. So we're considering the plan today, and we're endorsing the further work that's going to be carried forward through the Short Life Working Group. And I think that particularly the points that Stuart made in his introductory remarks about just having more detail about the wider workforce that are out with health and social care, Granite City Consortium and so on, also clarifying how we're going to tackle inequalities through our workforce plan, how we're using digital and our aspirations around modelling and just having a good sense of where we want to be, what success will look like in 3 years. Will be helpful, so we welcome that coming back. Okay, I don't see anyone objecting, so we're happy to agree those recommendations, and we look to the final report coming back later in the year. Yeah,
thank you.
Okay, thank you. Just want to pause for a second and just check with people. I'm wondering if we get through the IJB agenda, we can then have a break between this and our seminar, but are folk really needing to go and have a break now? So thumbs up if you're just happy to keep going with this agenda, and then we'll have a break between this and our seminar. Is that okay with folk? Yes, yes. Generally, okay. We'll do that then, and that should give us half an hour, at least half an hour of a break between this and the seminar at 2 o'clock. Mike. Hello, Mike. In you come.
Sorry, it was better for other people when they couldn't hear me. You wouldn't be surprised that I'm going to comment on this. We have to get much sharper on this, and that's not a criticism of you, because this is, when you're asking people, they have a tendency to say they will do something. So in other words, we'll go on with this meeting, we will do this, we will do that. We need to hear it set out properly so that there are breaks already built in. No argument that way, and that why there is proper distance between each of these things, including between the meeting and the seminar. It's something that we were speaking about the other day. We are absolutely terrible at doing this. Sandra has tried many times within the city to set up something that works, and every time it starts off well and it slips off. This is the future. Yeah, we need to get a grip, because if you can't do it, how do you expect your staff to be able to do it? So you're setting an extremely bad example, people. So that's my sermon for today. Thank you.
I suppose, Mike, I'm trying to do the opposite and think we might get a longer break and separate the meeting from the seminar by doing it this way, but we absolutely need to have breaks in these meetings.
I made it, Mayor Luan, that it needs to be set up so that we already can, that there is things, so that there's no pressure on somebody to say, yeah, okay, and I'll keep going because can forever. So yeah, we need to do this better. Simple as that. Thank you. Okay, I'm not being critical of you in person.
No.
Or simply of the system.
So maybe it's about looking at our Teams links and actually just setting up the meetings with separation breaks in them. Yeah, take that on. That's something we can absolutely look at, Mike. It's a fair point. Okay, right. Thank you, Mike. We will carry on, but we will have a break definitely soon. So we have covered the workforce plan. We're going to hold back on fast track cities at the moment, as per Sandy's request. So we'll go now to Link Practitioner Service, and I see Ian is on the screen. Ian, do you want to introduce this paper for us today?
Yes, I will do. Thank you, Chair. So good afternoon, everyone. Before you is the business case for the new Link Practitioner contract. This is a primary care improvement plan contract, and the funding will be taken from the PSIP budget. We're asking for the board's approval to go out to tender to source a provider to deliver the next Link Practitioner contract on behalf of the partnership from the 1st of April 2023. The contract period will be for 4 years, with a review taking place in year 3 to evaluate provider performance and contract delivery. If the partnership was assured on these, we are asking for delegated authority to be able to extend the contract for an additional 3 years. The Link Practitioner Service is a social prescribing service to help patients manage non-clinical issues which are having an impact on their health and well-being. Referrals are usually made to the service by GPs or primary care staff. Common referrals are for mental health support, social isolation, loneliness, finances, and housing. Demand for the service has been increasing, with a 16.2% increase in referrals to the Link service last year. The Link Practitioner Service will help the partnership to achieve all 4 aims of its strategic plan. It will align with the local outcome improvement plan. It'll help the partnership to achieve the 9 national health and wellbeing outcomes and support the Scottish Government's target of having 250 community link workers across Scotland. It will also help us meet the requirement of the 2018 GMS contract to take pressure off primary care colleagues and enable GPs to undertake their duties as expert medical generalists. During the process, we've undertaken a collaborative commissioning activity involving members of the public, including representatives from our locality empowerment groups, patients, GPs and primary care colleagues, link practitioner staff, public partners and prospective third sector providers. We've tried to align as much as possible with the Thiele report's findings on ethical commissioning. The process has informed the business case before you, our service outcomes and our procurement approach. Finally, the Link Practitioner Service has been in place since 2018, and we want to build on the good foundations while recognising that the landscape has got significantly more challenging with the COVID-19 pandemic, the cost of living increase and rising health inequalities. We want a service that continues to innovate and strengthen the primary care sector and achieve all 7 service outcomes we have co-produced together. Happy to answer any questions from board members.
Thanks, Ian. That's a really helpful overview. I'll just give people a second to see if there are any questions. Clearly a very important service, and we were one of the first IGBs to introduce link workers, which seems like a long time ago now, Ian. I remember way back. I see John's hand up, John Tomlinson, and then Dina.
Yeah, thank you, Chair, and thanks, Ian, for the outline. The recommendation that the 3-year extension might be delegated to the Chief Officer. I'm just a little bit curious about the need to amend the contract in light of experience, and if that's delegated as well or not. And I suppose, given a report on progress and a recommendation back to the IJB to approve, I probably feel a bit more comfortable that that might come back because there might be a need to adjust the contract. Just, can you reassure me that that's not needed?
Yes, so I think the idea is we want to have a longer contract, and that was definitely favoured by the PSIP group and our attendees at the Collaborative Commission workshops amongst all our main stakeholders. I suppose the idea is that a longer contract allows innovation and relationship building a chance to develop and allows the service to really go on and actually do the job without having to look over their shoulders too much. But what we want to do is to balance that with an uncertain strategic environment. So if we have a look at after 3 years, we can have a look at contractor performance. Are they delivering the service outcomes we co-produced together? What's the strategic environment like? What's the financial position like? And we can have a look at that review, and I'd be quite happy to take that review to the IGB in 3 years' time before we take a decision on that.
Okay, I suppose my point is about the need to adjust the contract and then the IJB being cited on that. I mean, I'm quite comfortable about the long-term approach for a contractor, and that's monitored through the commissioning. I just want to be assured that we have that flexibility in the contract, that we'll adjust it on the basis of need at the time. I mean, a week is a long time in health and social care these days, so 3 years on. I see Sandra's wanted to come in.
Yeah, I suppose it's building on the principles, John, that we've used for the Granite City Consortium about having a duration of contract that gives the provider that stability, allows us to have stability in moving forward. But also our learning from the GCC contract is that given the volatile state of like economic, currently the financial position where we are with that at a macro environment means that it gives the provider a stability as well for us to be able to review and say, for example, if there was a significant rise in costs or a reduction in GP practice, anything at all, anything that may well impact on the contract, at least there is a point in the contract where it can formally get reviewed and sit down. It's to give if you like, a stability for both parties. So it is on the taking on board the length of contract that we've got, but building in a bit of a safety net for both the provider as well as ourselves. I'm not sure if that gives you more assurance. The contract will say that there'll be key things that could be negotiated, or unless I'm picking up correctly, is it would be about picking up key things in the contract then that are up for negotiating. Would that be clearer? So, for example, if that was down to funding, if that was down to staffing, or whether that's down to the outcomes that were being looked at. It'll be specifics. Ian's nodding his head, so I'll let him come back in.
Okay.
John, is that what you're, sorry, Ian, can you come?
It was just to just agree with Sandra's point, and then just to add other things to this. I suppose that's the importance of contract monitoring and contract management. If we obviously we've got to go through the tender process and then agreeing with the contract, so there'll be a series of negotiations, and then once the negotiations agreed and the contract takes effect, to have really robust and effective contract managing and monitoring arrangements. Not just meetings, but reports, annual reports, and to make sure that both parties are clear on what our expectations are and what the challenges in the strategic environment is. So I think you're right in saying that there needs to be a degree of flexibility, because the strategic environment is very variable and changeable just now.
Okay, so where have we, just to be clear, where have we got to with that? Because I'm content to leave that with the chief officer, but there's a kind of threshold at some point where you might want something significantly different, and that presumably needs to come back through the IJB.
I suppose if there is a significant change to that would markedly change the service outcomes from the ones that we've co-produced over the collaborative commissioning sessions, if there was a market change, I think there'd be a case for coming back to the IGB in that circumstances. But I'd be happy, whether it's an annual update through the chief officer report, to give an overview of how the contract has been managed and delivered, and that would provide members of an opportunity to provide some feedback and hopefully provide you with the assurance that you need.
Yeah, I'm happy with that. Thanks.
Okay, so just to clarify my understanding, and so we're saying that on an annual basis there will be a part in the chief officer report that will give an overview of the progress around this contract, and if there has to be any significant changes to the contract at the end of the year 4 review, that will come to the IJB for consideration.
Yes.
Yeah.
What I can commit to as well is that we, in the tender documents, we'll ask for an annual performance report from the successful provider, and we could provide that if that would satisfy members as well.
Yeah. John, are you happy with that? Is that kind of where you're just need to have touch points with the IJB and how this is progressing? Is that what you're looking for?
Yes, I'm happy with that. And whether it has to be annual, it can be a bit longer than that if that fits with the reporting cycles.
Okay, thanks, John. Well, we'll make sure we capture those points in the minute for today's meeting. Okay, we've got Dina next, and then John Cook.
Thank you, Luan. So for me, link services are very important because it actually directs people in need to the right places to get the support that they need. So for me, one of the biggest issues here is representation. So some of the referral reasons here is finance and money, housing and homelessness, benefits. When I mean representation, I'm talking about people on visas, people dealing with immigration. Most of them in here, students, international students and dependents, they have a no recourse to public funds status on their visas. And there is not many organizations here in Aberdeen that know how to deal with these cases. Particularly, for an example, what I can give is women facing domestic violence. The level of support that they can get if they have no recourse to public funds, charities here, third sector organizations here, link services don't know about it. If a benefits application or a crisis grant is applied under their name, and the person who is dealing with them don't have the specialist training to deal with the case and applying these benefits, it risks these people losing their visas. because it can impact it. It's a visa violation. I have worked in the last 2 years with women facing domestic violence, and I'm bringing this example because of the Nordic Coastal Public Funds issue here. And there is no service in Aberdeen, so we've had to work with Edinburgh Outreach Services to make sure that these people are represented. And now we have a lot more international students, and we have a lot more people with these, visa statuses here in Aberdeen. And I don't think these services here is representing them fully. I just want to know how we can bring that specialist skill into these link services, because it is a very important aspect of it. Why this discussion has not had before, I don't know, but I guess now we have representation on board to have this discussion initiated. I want to know how we can incorporate representation of these people and the specialist needs that they need through our link services. Thanks.
Thank you, Councillor. Happy to pick that up for yourself, Chair. So equalities and diversity and really putting a prime focus on equity and making sure that hard to reach groups are represented and have the advocacy that they need is absolutely crucial, and we'll include that within our tender documentation to make sure that the providers who are bidding for the contract provide us with the assurance that we need. Once we've been, obviously we'll have clarification presentations as well, and it will provide opportunities for the evaluation panel to ask questions in this area as well. Once the contract is agreed, or prior to the contract agreed, we'll have a performance framework that will be mutually agreed with ourselves and with the provider, and we be very keen, not more keen, it will be in there. We'll have KPIs on equalities to make sure that they are achieving all the aspects of equalities and align with the Equality Act that they need to do. Advocacy will be a very, very important thing. If there's gaps in the services in Aberdeen, one of the key roles of link workers is to make sure that they can source that support, whether that's on a national basis. You mentioned services in Edinburgh, but that'll be a key role for link workers moving forward. I hope that answers your question.
Dina, do you want to come back?
Yeah, I do want to come back. I understand the need for equity and diversity representation, but these are specialist skills that is needed in order to, it's not equality and diversity training is not going to cut it. These are specialist skills that you needed. You need to work with immigration officers, lawyers, solicitors maybe, to understand the impact of it. There's so much more that is, intersectional issues that these people, marginalized and vulnerable people, go through. We need to make sure that we get people who are specialists in this area, and that's what I'm trying to say.
Yeah, I totally understand.
I see Sandra's looking to come in, Ian.
Yeah, can I come in? So I absolutely think it's a very valid point that you raised, Dina. However, I think the link workers that we have at the moment in the paper before us is our link workers that are attached to our primary care improvement plan, which are specifically in our GPs. I think the issues that you're raising are very specialist from a link worker, and it would be, I'm not sure that we'd be able to skill up every single link worker with the level and the depth of knowledge that you're highlighting. However, what we can do is take that offline, and we can take that away with looking at other areas, working with our third sector partners, particularly Women Against Violence, looking at our refugee hub, all of that we're working alongside. But I'm not sure that that's relevant for this paper and relevant for these link workers who are much more around about social prescribing and about that broader whole context, and not having specialist level of knowledge and skills. As you say, working with the Home Office, etc., that isn't the purpose of this contract here. So happy to take that up offline, but not quite sure that that's relevant to these workers here. So hopefully that helps answer your question.
I think that's a discussion to have, and of course in these discussions it will be revealed that the relevance will be revealed as well, and I'm happy to have the discussion offline with you later. Thanks.
Thanks, Dina. So I'll move on. 2 more people with their hands up, and then we'll come on to recommendations here. So I see John and Martin.
Thanks. Yeah, just Actually, just a thought. I wasn't going to raise this, but just a thought on the issue Dina's raised. I occasionally get immigration and visa queries coming from constituents. I normally just refer them to the local MP, because it's the local MP's office that deal with the Home Office typically. That's just a thought for the offline discussion. That wasn't actually what I was going to bring up. I think the point that John Tomlinson raised was a good one around the just having IJB having sight of what we're doing if we're going to extend. And the other thing is really just kind of for confirmation. I'll look at the stats in this paper. So 250,000 GP contacts saved in a year, and 86% of GPs think this is a valued service. I'm thinking, wow, this is really good stuff, and we need to continue with this. I'm guessing that we are saying we're actually quite happy with the way that SAMH have operated things, and just to get confirmation that when we do go out to retender, assuming that is the decision as recommended, they would be happy to retender.
We don't know at this stage whether SAMH are going to retender. But in terms of your comment on SAMH, we've done a programme review, and SAMH have performed quite well. I think particularly during a global pandemic, which is like a once-in-century event, I think that's got to be noted. And it is quite an innovative service. Aberdeen City was one of the first social prescribing link practitioner service to operate. And we've generally been satisfied, and we've received that assurance that we need, both in governance and contract performance and service delivery, through our regular quarterly contract monitoring and management meetings, as well as the data that they provide us. We would welcome as wide range of providers entering into the procurement process as possible.
Thanks, that's helpful. And apologies for asking about 4 questions in one there. So thanks for that.
Thanks, John. I'll go to Martin next, and then Christian with the final question on this paper today.
Yeah, sorry, this might be just repetitive, but I think it's worth making the comment that the link contract is of quite a considerable value, and we will want to make sure that we get best use, best outcomes possible from it. There's considerable pressures and lack of resources in primary healthcare. So I think that there's a real opportunity here to cater to patient demand in a really positive and imaginative way. So it's just the ongoing scrutiny of performance. I mean, is there sufficient scrutiny